Just to welcome everyone to the meeting today. I know we've just Nuala and Diane online at this stage, and just remind members again of your microphones and all of that. Today we will have a number of briefings, so ask people to be very mindful when asking questions because we have a very heavy agenda, so we want to make sure we get the most out of it. We have a briefing from the RQIA on its role, a briefing from the Allied Health Professions Federation on the role of health professionals in transformation and modernisation of healthcare, and we have departmental officials who will provide a briefing on domiciliary care. So the meeting can be open to the public now. And as per the norm, the committee meeting will be recorded and broadcast through Parliament buildings online. Just to remind members to keep their mobile phones on silent, and that anyone in the public gallery can connect to the Assembly Wi-Fi, and the details are on the seats. I have apologies from Colin McGrath. I have no other apologies at this stage. Other members may join later remotely. Alan Robinson, I think, and Alan Chambers have both said they're hoping to join, so we expect them later. I have no chairperson's business. Under the draft minutes, if I could refer members to the draft minutes of the meeting held on the 13th of June, which is page 7 of your meeting pack. Are members content with the minutes as drafted? Yeah, and I have no matters arising. Members, just because over the last few weeks we have had some difficulties with quorum, we have a couple of items at the end of the agenda that I'm going to bring forward because we do need decision on them. So from item number 9, which is there's 2 SRs and an SL1. So if members are happy enough while we have quorum, I just want to make sure we get these through. So if I could refer you to item number 9 of your pack, which is page 42, and the most recent Examiner of Statutory Rules report, which is page 9 of your table papers. This is the SR 2024-116, the Health and Social Care Pension Scheme Member Contributions Amendment Regulations ANI 2024, and this statutory rule introduces changes to the member contribution structure for members of the HSE pension scheme and will uplift banding structure in line with 2023-24 Agenda for Change Pay Award. The rule is subject to negative resolution procedure, and the Examiner Statutory Rules has reported on the SR and has no issues to report to the committee. Are members content with the SR? Yeah. Okay, so just to agree then that the Committee for Health has considered SR 2024-116, the Health and Social Care Pension Scheme Member Contributions Amendment Regulations NI 2024, and has no objection to the rule. Item number 10 then is the SR 2024-117, the Health and Social Care Pension Scheme Amendment number 2 Regulations NI 2024, and if I could refer members to tabs 10 from page 57 of your pack. This statutory rule will introduce changes to the member contributions structure and makes changes to abatement provisions for special class status members, and will make minor amendments regarding partial retirement and consequential amendments relating to the removal of the lifetime allowance by the Finance Act 2024. The rule is subject to negative resolution procedure, and the Examiner of Statutory Rules has not yet reported on the SR, so members will therefore be agreeing to the rule subject to the report from the Examiner of Statutory Rules. So are members content with the SR this stage? Agreed. So members agree that the Committee for Health has considered SR 2024-117, the Health and Social Care Pension Scheme Amendment number 2 Regulations Northern Ireland 2024, and subject to the Examiner of Statutory Rules report, has no objection to the rule. Item number 11 then is SL1, the Period Products Department of Health Specified Public Service Bodies Regulations NI 2024, and page 94 of your pack. Members, the Department is proposing to make a statutory rule that will specify the 6 trusts, including the ambulance service, as public bodies must ensure period products are obtainable free of charge as per the requirement in section 22A of the Period Products Free Provision Act Northern Ireland 2022, which refers to hospital premises. The statutory rule will be subject to the draft affirmative procedure, and I think we do need a wee bit more clarity on this, because particularly around the ambulance service and how that will work in relation to that. So if members are content, I would suggest that we write to the department to get some further clarity on the premise of the duty, on the premises the duty will apply to, particularly in relation to the ambulance trust in the ambulance service. We also need to get some detail on the financial implications, how much that will cost. And I think if we could maybe get some information on the position in the south of Ireland and in Britain as well, and to hear the feedback of the bodies that have been consulted with, and a copy of the draft regulations when available. So are members content with those suggestions?
Yes.
Okay, thank you. So we're content then to await a response from the department before giving further consideration to the merits of the policy. Yeah. Okay, thank you, members, for doing that. Those are the 3 items for decision. We now move back to the start of your agenda and to the first briefing, which is a briefing from the Regulation Quality Improvement Authority, RQIA, and this will be the role of RQIA. If I could refer members to the briefing at page 16 of your pack, and there is some correspondence as well from individuals in relation to the deceased patients of the former neurologist Michael Watt, which is page 22, an individual regarding the Northern Trust, page 23 and page 130, from the BDA on dental tourism and events being held in hotels in and around Belfast, which is page 7 of your table papers, and from Participation in the Practice of Rights, PPR, on its campaign New Script for Mental Health and Transparency around Mental Health Regulation, which is page 8 of your table papers. So members will have all of that. So give us a second. Okay, you're both very welcome. In attendance today we have Christine Collins, MBE Chairperson for RQIA, and Breach Donaghy, Chief Executive of RQIA. So thank you both for your time today. We have about 45 minutes for this session, as we have a number of briefings today. So the session will be covered by Hansard. So if I could invite you to make your brief opening remarks, and then we'll open it up for some questions. So thank you both.
That's great. Thank you very much indeed, and thank you for your time in seeing us in this session. Breach is Breach, and I'm sure a lot of you know her well already. Malachi is sitting behind us, and anything we say that's right is Breach and Mai's thing, and anything we say is wrong is Malachi's. No, seriously, I know you've already had the written briefing material, and I don't propose to go through that. The things we'd like to highlight are really our very different powers in relation to registered services, which by and large are the services provided by the independent sector, as against the powers that we have for the HSC statutory sector services, and again the further different powers we have under the mental health order. I think we have 3 quite distinct sets of duties and powers. The main focus of our work in HSC services is on the duty of quality, because that was came into being in the 2003 order at the same time as RQIA was created, and we are charged with sort of overseeing how that's working in the HSC sector. The mental health order responsibilities, I mean, they are old because they date back to 1986, but they do give us quite a raft of things that we can do, a raft of responsibilities, which we're busily engaged at the moment in really scrutinising, because I think it had fallen into a bit of desuetude. Those mental health order responsibilities are very person-focused, as distinct from the 2003 order responsibilities, which are looking largely at organisations or services. Mental health is all about protecting individuals with mental health conditions. And then the next bit is what we would call part 3 of the mental health order, the registration and inspection and enforcement of the approximately 1,500 registered entities that we look after in Northern Ireland. So that's sort of very brief overview. Breach?
Yes, thank you, Christine, and everyone, thank you for inviting us. Just to share with you a little bit of insight into some of the areas that we cover, drilling in a little bit further, but only very modestly. And just to give you an overview, RQI is a small organisation, there's 140 staff. If we were all there, that's head count, so to speak. We have a budget of around 10 million. The 90% of that comes from public funding. At 1 million or thereabouts comes from fees we can raise with registered providers, including care homes and dentists, for example, private hospitals. I'll talk a little bit more about that should you wish later. We're based in Belfast, though we have a small office down in Omagh, but we cover all of the regulation across the whole of Northern Ireland. So, for example, 470 care homes across Northern Ireland, 400 dental practices, multiple domiciliary care agencies and so on. As Christine says, it's the largest part of our work because the legislation requires us to register and inspect those services on a particular frequency. Not so when you come to statutory, ED departments, medical wards, maternity units. That's not the case. There are lots of challenges. Legislation, Christine has mentioned, is certainly one of them. Although it's important to say that the legislation for the statutory services gives us a broad remit to inspect and enter into any of the HSE premises. It's largely a capacity issue that might prevent you from going further than we ordinarily do. And equally on the mental health order, whilst it's quite old, 1986, actually, it provides a very broad umbrella of following through individual patients. That's the big difference in the two pieces of legislation. The 2003 orders, we tend to call it, which created RQIA back in 2003, is service-based. So you inspect care homes, you inspect domiciliary care services, you inspect the service. Yes, you speak to patients and families as part of inspecting that service, but it's a service-based model. That's not the case for the mental health order. It's about people. So for that element, you follow the individual and you look at the care and treatment afforded to them wherever they're living. And this is a big challenge, of course, in terms of the volume and growth in the need for scrutiny and quality in mental health services. So legislation is a problem when you come to registered services, the care homes, the dentists, the private hospitals, because it's old and it demands you to go to those services on a particular frequency basis, and we would challenge if that's necessarily the best way. But just in hearing some of the conversation as I entered the room, it also has gaps in it. So, for example, it does not allow for high street providers, so providers of different kinds of services, sports clinics, fertility clinics, those types of services where they're not run by a doctor, to be perfectly honest, fall outside all of the legislation. Online providers, tourism, healthcare tourism, falls outside. So there are gaps in the legislation as well as limitations of it. But a lot of it for statutory services and mental health is a broad range, and less demand for the need for changes there. I've mentioned the fees and the way we're funded, and we have about £10 million. The fees that we can raise for those registered services, well, it absorbs nearly all of our capacity. Those fees remain the same as when they were established in 2005. So the price for registering a care home, for example, is £952. It was £952 in 2005. It still is. And we would suggest that there needs to be a new model that funds regulation that allows it to grow with those sectors growing. It doesn't where you're funded from public funding, obviously with the limitations on public funding. But there is an avenue there for resolution to that we would suggest and can discuss with you as to how that might be resolved. So there's all that area of registration. I was going to just mention the fact that this week, or last week perhaps it was, we submitted our management plan to the department who endorsed it. And I'm just going to mention 2 or 3 things in it and finish on that. Part of what we're trying to do as a regulator is use our role to add leverage, if you like, to add to the ability of the whole system to improve safety and quality. One of the things we've been focusing on is enabling trusts and others, but largely the trusts, to develop this idea of a culture of openness. And very happy to speak with you about the kinds of things we're doing as a regulator to encourage that. And we appreciate that we have a lot of leverage in that regard. There's no doubt we ourselves need to keep working on improving how we listen to families and service users, and indeed to staff, and how they contribute to inspections and the actions we take. We need to work and are working better, collaborating better with other regulators. We're the service regulator in Northern Ireland for health and social care, but there are many professional regulators, the General Medical Council, the Nurse and Midwifery Council, who register and regulate the professional individuals. But there is clearly a need out of the public inquiries we've already seen that there must the Swiss cheese effect, everybody regulating in similar environments, but sometimes and very often maybe missing the point. So we've just recently agreed with and launched what we call an emerging concerns protocol. It's a shared intelligence framework, very big words to describe us better working together, sharing information within all the confines of information governance and all of that, but working better together. It's very early days. It'll take a lot of work and a lot of effort and commitment, but a commitment to learning out of the neurology inquiry, for example, and others, that regulation must be better joined up as well. There's lots of areas to be strengthened as a result of all of that. We're trying also to use our role to raise awareness of and inform service change. So we're out doing reviews largely in the world of registered services. We largely do inspections, care homes, dentists, all of that. In the world of HSE, we largely do reviews. So at the moment, for example, we're out doing review in the South West Acute Hospital. We've been asked to look there at the pathways that are in place in relation to the temporary changes in emergency surgery. We're out doing an investigation actually into the commissioning of residential care for people with learning disability. Through these types of approaches and engaging with people and listening and publishing our findings, we plan to ensure that informs service change and improvement. So it's using our role better to inform that wider need for transformation. So that's me saying just a little tiny bit about things, and Christine maybe close on our...
Yes, I mean, we have a vast lot of things that we could talk about, and we're in your hands as to what you particularly want to tackle today. I know you'll appreciate that this isn't the appropriate forum for us to get into detail about any individual case, both confidentiality reasons, but also because some of these processes are actually judicial in nature, and once they're in train, they have to just be allowed to take their course. But that's the only caveat. And even if any of those are raised, we'll try and describe our general approach rather than focusing on any individual point. But that's it from us. So.
Okay, no, thank you both for that introduction and for your briefing paper, because I suppose that has allowed us then to maybe have some questions and I'm prepared. I have a couple of questions then I'll open up. Others may want to cover different aspects of this. So I suppose really the first thing I really would like to maybe hear your views on is obviously, and you're well aware of this, you did allude to it, Breach, in your remarks, is the ongoing crisis in health and social care, okay, and down to the financial situation, budgets, etc. And we've had loads of different organisations, bodies, professional bodies with us in committee since the Assembly was restored in February. And one of the things that has really jumped out at me is the real risk to patients and patient safety due to lack of capacity, mainly in workforce. So I was just, based on your role then, because that can lead to issues arising, and all of that. And we have a briefing, I think, next week on the SAIs as well, which is linked to some of this stuff too. So I would be good to hear your assessment of that in relation to patient safety and in terms of your role. And do you see a rise in issues in terms of that? That you could say that it's services are under severe pressure, staff are under pressure, and that's because of the crisis in the workforce at the minute. So,
you would like me to start?
Yes, I was going to say, where you go, please.
I would say yes to all of the above. Now, it would be difficult for me to say, do you see a rising trend? Just to qualify, because we do not have a regular inspection programme of health and social care trust services. We do inspect from time to time. We do carry out reviews. But just quickly to say, for example, last year we did 1,800 inspections of registered services. And I keep saying care homes, dentists, whatever. We did 12 inspections or pieces of work around health and social care statutory services. They're not comparable. An inspection of a care home is not comparable to us doing a piece of work in Craigavon Hospital where we looked at people who were delayed beyond their medically fit date or whatever you might want to call it. And we looked at the whole system there. We spoke with care home providers, domiciliary care, both statutory and private, local GPs and so on. I mean, that would count as one review or one inspection compared to an inspection of a care home. They're totally different. But I wouldn't be able to say trends, but I would add to what you've said. You're saying it increases the risk. Well, we would say people are coming to harm. There is evidence of people coming to harm. It's beyond the stage of risk of coming to harm.
Yeah.
They are coming to harm. People who are delayed in hospital, largely older people, but not exclusively. And I'm telling you, and I know you've heard it from other sources, and I suppose all we can do is affirm that the regulation role also confirms what you've heard from professionals, managers, commissioners and others. People are coming to harm as a result. People delayed in hospital who need to be out living in their own home or supported elsewhere, lose their ability to be independent. It changes dramatically their outlook and what they're capable. You will have heard of all of this. All of our work endorses that. The same when we came to look at the Royal Victoria ED, and I would say it refers to every one of the EDs. People backed up in ambulances, delayed in, spilling outside the ED, EDs doing their level best. It's very difficult too as a regulator, I think. We report on these things. And people will say to us, all sorts of people, the public, staff, others, well, that's not enough. What are you going to do about it? The best we can do is to persist in articulating the harm that's being caused. We will not desist from that. I know people say, oh, well, others have said that you've added nothing new. No, we have added new because we've added the evidence. Regulation's all about evidence. It's not anecdotal, it's not dramatic, it's not any of those things. It's evidence-based. And yes, we listen to people, but we compare every service we inspect, including the HSC, when we inspect them, to the HSC quality standards, which were written in 2006. Might sound like a bit old school, but actually they're very good. They're very comprehensive. And when we've inspected service, we have found failings on, there's 5 standards, failings on all of those. And that's not because staff weren't making effort. You know that, I know it. And it's not because managers aren't making effort. And it's not because a lot of people are thinking about money and all those things, workforce, all of that. But it goes beyond risk. It's causing harm. And we will probably see the results of it in the decades to come.
Yeah. No, and I think, that's kind of what I expected to hear. I think that's unfortunately where we're at, unless something's done, and we need to see that proper transformation in our health service. And it leads into, and you'll have heard a lot around this, and it's a question I put into the department around unfunded beds. And obviously there's a lot of beds, corridor beds, beds being added into wards that aren't funded, which causes great concern. And that adds into that issue around increasing risk, but also patients coming to harm. And is that something that then, part of maybe some of the work that you have already done that you're feeding into the department to, around what you're seeing and what the harm that is being done or the increased risk?
Yes. And give the example of it was that work in the Royal Victoria. Now it's about 18 months or more ago, but it identified all the, I'm going to say, spill out areas that were being used, all those additional beds. And I saw the Assembly question, actually I liaised on that with the Royal College of Nursing about it and engaged with Rita Devlin about the definitions of all those beds. Boarding beds, corridor beds, escalation beds, and they're not part of the commissioned programme. Look, they add increased risk in the RVH, and I hate using that one example because I am certain this is repeated in every ED, so please extend that definition beyond the area we looked at. This was a serious problem. We found several areas, ED trying to be something it isn't. ED is meant to be, as you and I know, trying to move people through the emergency part of their treatment plan, but it had become ward. It was accommodating people for days on time into these, extra beds, escalation beds, boarding beds, and so on. It adds to it. The other thing I suppose I would say is we do try to caution, and I say we, colleagues and inspectors and others, also don't want trusts to feel that there aren't some actions they can take. Where you find that you do have to, just by sheer demand, have to create those additional spaces, then make them as safe and dignified as you can. So make sure that those staff that you are drawing in, it's never sufficient, but where there's locum staff or agency staff, give them time to be orientated as best you can. Increase or look at your frequency of infection prevention control, provide lockers and Cardex, and be clear on who's in charge and what's the reporting arrangements. It won't resolve the matter, but it would improve the safety of those situations, and that's what we recommended when we did those inspections before. So it's not to diminish. I think sometimes people say, you talk about improving, cleaning and safety. You're missing the point. No, we're not saying those things resolve the matter. They don't. But it's also about saying to people, while you're working in that environment, think about these extra steps that need to be taken to try to keep people safer.
And maybe you can't answer this, but see, in terms of them, whenever you're making recommendations, what sort of feedback are you getting from the department? Or, is it?
Well, our recommendations on those, go to the trust first and foremost. And what we've tried to do, and increasingly tried to do, is not to ask the trust to do something that's outside their control. And in that inspection, for example, and in the one in Craigavon, which was, we called it a system inspection, but there were recommendations there for both the trust and other local providers and for the department. I mean, social care reform, which I know, because I see you speaking about it and talking about it, is essential to this. It's one of the issues why we all fear these potential, issues around financial pressures might draw us all to look at areas where you can stop spending some money very quickly. And because a good part of the social care provision through nursing homes and to some extent domiciliary care and supported living and what have you, much of it is provided through a range of independent providers, sometimes through contracts and what have you. These sorts of areas can sometimes quickly draw attention to areas where you could maybe spend a bit less, not because you have less need, but because of the potential to spend less on a contract or something. Those are the very areas that we recommended in the system inspection needed investment and reform, and we encourage the department in the efforts that they're making to do and take forward social care reform. We all know this means care workers, all the terms and conditions, all of those things need to be addressed, or we will never have sufficient capacity in daycare, domiciliary care, residential care, all of those things. So, we do recommend the department, and I shared those reports with the department. They accepted them. I don't think there was anybody saying what we'd found was, a surprise to them. But sadly, it's further endorsement of the, others who are reporting the same types of, but we come at it from a regulatory point of view.
Yeah, no, I understand what you're saying. And I suppose we have a briefing on domiciliary care today, so we can maybe draw some of that out as part of that. I've just two final questions, and then I'll open up to others. Nobody wants trying to get in. In the briefing, you mentioned about moving to an intelligence-led inspection regime, and for me, I can see maybe two sides to that. I suppose my concern would be that things could potentially be missed, through routine inspections. So it was just to try and get an understanding of that, why you think that would be a better idea. Is it purely down to budget constraints or capacity issues? Or is it down to, as you alluded to earlier, Bridge, in terms of what your remit is, what you actually have the authority to do? Is it that you think you could do with more power to be able to deliver better for patients and their families?
No, well, I think... Oh, sorry, Christine.
I think if... We've thought about it as an authority a lot, and I have to say that as an authority it is not a comfortable position to be in a position where the regulations say that we should be visiting every care home twice a year, and we do not have the capacity to do that. That's a reality. So then what we have to do is actually look at our resources and work out what's the very best way of providing the best network of safety that we can with the resources we've got. And so, as an authority, we've consciously taken the decision that we will make sure we visit everything that we're supposed to visit at least once a year. If it's supposed to be visited twice a year, we will go there physically at least once a year. We will use then the resources that we have and the methodologies we have, which Bridge will talk about, to identify the ones where we reckon there is a higher risk. And we will go into those as many times as it needs us to go in. but that is the better use of the resource rather than just trotting around with clipboards by rote twice and being a sort of tick box exercise. We're really trying to be intelligent about how we do this. But that is a conscious decision that the authority has had to take, and with reluctance, because, ideal world, I would like to have enough staff that we could go in twice every year, and also on top of that, go and visit any care home or anything that needed us to visit more often. We could be in there as often as the signals said there's an issue. But that's something the authority has had to take a decision on. So that's where we are with that. I quite take your point. I think there was a case in England where, I think it was Ofsted, don't have a set frequency of inspecting schools. So they hadn't gone to this school for 5 years. And it had actually gone very much downhill, which is why I do think there needs to be a regular visitation to pick that up. But I think you also need to be able to identify the ones that are at risk and then focus on those and have the capacity to do it.
No, I have nothing to add. I think that covers it, yes, Chris.
Yeah, no, and I think from my own perspective as well, my fear would be that things can slip through the net, and even if you're waiting on someone to report, it can be too far gone at that stage. So I would have concerns around that, and maybe that's something we can look at as well. To our discussion. My final question then is just in relation to the review of deceased patients, and I know Bridget had mentioned the neurology inquiry, so it's just to understand the process a wee bit better, just what are the next steps, and have we any time frames in relation to that, because I know certainly committee members will have been contacted quite regularly by families affected by that, and we want to ensure that everyone is getting what they need out of that, because it's so important.
Well, look, not to delay on getting straight to your answer, but I would maybe just add a couple of points afterwards. It is a decision for the Department of Health as to whether and when and how that next, if there is a further stage of the deceased patient review of records to happen. But we have engaged strongly with the department on it. We've put forward proposals as to how we might take it forward if that was to be the case, and we would stand ready, I suppose I would say, if we are commissioned to do that work. I've worked in RQIA for just about 3 years, and I would say to you, and I know I reflect on many of the staff and the authority members, it was an absolute privilege for us to carry out that piece of work for the 44 families that we did. It was tremendously difficult for them, and that is an understatement, and I know that because they told us so. Entering into further, we do so with the right intent, and respect and all of that, but it is a tremendously difficult process, we know that, but we're ready to take it forward. I know the department are considering it, and I think they've said that it's imminent for them to minister and others to make decisions about it. We have a number of families who've made contact with us that they would like to be considered should there be another phase, just under 20 families, and we continue to keep in touch with them very modestly, just to say we've not forgotten about you. And as soon as we know anything further, we'll keep in touch with you. But we do need to wait to be commissioned to take forward that work.
Yes, we're waiting on that decision.
And the decision,
from the Minister.
yeah.
Okay,
Yes.
maybe we can follow that up. Okay, sorry, I know I've asked quite a number of questions and others are waiting. I have Orlia next.
Yes, thanks very much, and thank you both for your answers so far. So just to go back to in terms of the intelligent-led approach to your inspections and what's the best way that you can take that forward, I wanted to ask if the RQIA has given any consideration to developing a sort of specific planned programme in terms of inspections into community mental health services. And the second part of that question would be, just you had spoke earlier around the mental health order and the difference between, what you are obliged to carry out through legislation and whatever. And I'm just wondering, have you had any conversations with the Department of Health, with the Minister, in terms of some of those gaps of the underpinning legislation? So if you had the support or backing from the department to maybe modify and change some of that, would it help your organisation to support in a more structured way the review and inspections of particularly community mental health services?
I think I'm going to hand over to Breach in a minute. But first of all, we haven't had any discussions with the Minister on this. I'll just put that up. Yep. We are in conversation, I think it's right to say, with the department continually. I think the difficulty is that changing legislation takes an awful lot of time.
Yep.
You know, I don't need to tell you that. And my guess is that if we were talking about brand new legislation, we're talking 5 years. And that doesn't help anybody here and now. So our focus is really more on the legislation we've got now. How can we make the best possible use of it? And that then links back into, and what resources have we got to do that with? And since the judicial review, which we conceded back in February, we have been working very hard to put in place the kind of systems, the processes, the protocols to be able to judge when we can actually use our powers and how best to use those powers, how to go about it. Breege, you can
Well, I'll only add
follow
briefly
on.
because I know there's other questions, but I'm going to try and say this as clearly as I can. But the priority, I think, right now, given the context Christina said, is no, I wouldn't prioritise inspections of community mental health services. Why? Because they fall under Part 4 of the 2003 order. They're largely provided by the trusts. The trusts are subject to statute duty of quality, etc. But I would love to talk for length of that. But the important point here is, and I mentioned it earlier, the mental health order lets us look at individual care. That's where we're concentrating. So going out and doing inspections of services and, you know, asking multiple people how was that, that's important, don't get me wrong, I'd love to be doing that. But what we are going to do and are doing is I've spoken to and engaged with several families over the last month, certainly since the judicial review was conceded, and we are undertaking inquiry, is the term used, into individual. The strength of this is it doesn't matter where the individual lives. I think this is very important for us to understand, us, and if we can explain to others, that's good as well. People are being resettled from Muckamore, thankfully. They'll be going to live in other types of places, you know, care homes, supported living and so on. Our legislation from the service point of view is pretty restrictive there, but the mental health order isn't. The mental health order allows us to follow an individual, so to speak. Capacity is always a problem, as Christine says. But I am more keen right now, within the confines we've got of capacity and legislation, that we use the mental health order to inquire into individual, you know, it's called detriment of care and, you know, treatment, keep under review the care of individuals with mental health disorder. This is the avenue we're going down. So we look at individual cases. If we had capacity, we would very be very delighted to do further. Particularly, I was speaking to families recently of the Patient Land Council, as you know, host platforms, engagement platforms. So I and some of my colleagues have, in the last couple of weeks were meeting with families with people with learning disability. On a separate occasion, I met with people who've carers and families of people with mental health issues. Meeting them again in August to explore it further. You know, they have many, many issues they need us to look at. They were raising with me that day, and I think I've seen in your records too about daycare services, for example, the capacity of daycare being normalised again after the pandemic and some of the restrictions and limitations of it, and all of the things you've seen about that. They were raising some of those things with me. I was talking to them as well about community mental health services generally. It's a case of there's so much to be done in mental health services. Not least this morning when we hear the press releases and so on about the mental health strategy and all of that. We would endorse all of that. Right now, with the legislation as it is, the mental health order, old as it is, offers a very, you know, broad ability for us to follow the individual wherever they might live. And that's not easy, I know, because it means engaging with families and the individual themselves, sometimes with legal people and trusts and everybody. It's difficult enough to navigate, and as Christine said, but you know there are some cases that sometimes you see in media and so on. But I can only say to you that we are working through those diligently as best we can, respecting the boundaries that we have, ensuring that people have consent and all of that. So that's the area we would prioritise at the moment because of resources and legislation. And I wouldn't move quickly to do general inspections of community mental health service. But I wouldn't rule out that we will certainly be looking at daycare at some point over the coming period. It's also in the public domain. We're currently doing an investigation into the commissioning arrangements by 2 of the trusts in the commissioning of learning disability residential care in the Belfast area. I'll be out meeting with families and others over the coming weeks as we investigate that. So much could be done. We'd love to do that, but when I'm out meeting with people, and we've held many engagement events to explain why we conceded the judicial review and so on, as I speak to the people, I'm upfront with them. No, we're not going to start doing regular inspections of community mental health services. Could we? Have we the authority? Yes. Do we have the resources? No, not if we're going to try and pursue the individual cases, following up from people who have been resettled from Muckamore, looking at people who are already living and coming across difficulties, and working with their families and others. That is where we would put our energy right now.
Okay, to be honest, that response does worry me slightly, and it's just because obviously my brief and my own political party is around mental health, so I engage a lot with individuals, families, groups working in the sector, community, voluntary and statutory, and I know that there has been a sense that there has been a lack of scrutiny for a very, very long time, and also a lack of reviews, a lack of inspections, and without getting into any individual cases, as you said earlier, you will know that there is a lot of examples out there where people have really sadly, tragically lost their lives for one reason or another in terms of mental health facilities. So could I ask, when the RQIA introduced the new sort of approach, the new protocol, in terms of the concerns that were raised around mental health community services, what has been the follow-on from that? So that new approach, to me, you're saying that due to resources there won't be any inspections or reviews?
You see, if we could go back over, and it's not easy and I'm maybe not explaining very well. Community services that I believe you're talking about are largely, exclusively provided by the Health and Social Care Trust. Yes, they do commission, independent providers maybe to provide daycare or day activities and so on. But they fall under the legislation that is not subject to regular inspections. None of the HSC services, maternity wards, medical wards, EDs, community mental health services, they are not subject to regular inspection. The legislation, there's no regulations, if you understand me. So it's not subject. So last year we did 1,800 inspections of registered services, which are, those services are not. Why? Because under the legislation, the Health and Social Care Trust has the statutory duty of quality. I suppose those who legislated for it must have considered trusts are established with trust boards, executives, lay people, they report to the Department of Health, etc., etc. They've got all the rigour, one would imagine. Our job there is to go out and check that they've put the rigour in place. It's focused on the standards and the governance, not the inspections. We sometimes do a handful of inspections, but there is no routine. This is what I'm trying to... There is no... Now, if somebody would like us to do routine inspections of health and social care trusts, maternity wards, medical wards, cardiology wards, community mental health services, we'd be very happy to do so.
Given the resources.
If we had the resources, yes. But the legislation, and I think it's powerful. People, have lost their lives. I've met with families who have lost people through homicide and mental health. That's why our approach through the individual case... Because although you look at the individual case, you clearly find lessons beyond the individual case. And we have the powers to do that. The legislation doesn't need changed. Mental health order already allows us to do that. We could do with more capacity, but we should, if we're concerned, and don't get me wrong, but if we're concerned about RQI not doing regular inspections of community mental health services provided by trusts, that is also the case for EDs, medical wards, children's services, all of them. No,
look, that's fair enough. But I suppose it goes back to the chair's remarks earlier in terms of, that all services are also feeling additional pressures, reduced staffing levels, and obviously you share those concerns that people are already coming to harm. So I think that it's just worrying that it doesn't seem that there's much safeguarding in place, even in terms of review and inspection. And I do think it's something that hopefully maybe as a health committee we can follow up directly with the department to maybe provide a bit of leadership on this, because there is definitely gaps there. And but take on board everything you have says around your own staffing, your own resourcing, and if you've had more of that, you know, that maybe, you know, your work would be able to be broadened out. My final question then is just around the funding and the staffing. So at the moment, how well equipped do you feel to carry out your duties with the funding and the staffing that you have at present? That's my final question.
I would start and Christine can finish maybe. Look, we're the same as every other organisation that you've met with that will, you know, explain how difficult it is with the funding we have. We're in that same boat. But what we're doing is, you know, owning the problem and saying, well, there's what we've got, 140 staff. I have 17 inspectors to inspect care homes. There are 470 care homes. You know, I've got 3.6 inspectors to inspect hospital services, 3.6. You know, so that's what I've got. We use intelligence. We could use it better if we had better IT, and we're going to get better IT. And the other thing is we have proposed solutions to this. It is possible for us to look towards a full cost recovery model. Other jurisdictions have it in place, where services are registered in England, for example, with CQC, and I am no expert in it, but all of the registration and regulation of those services is fully covered by the fees that are recovered from the registered provider. They are largely, in our world, CQC would be different, but in our world, they're largely independent providers. We're not diminishing that. It's adding and changing the cost of registering with RQIA. You know, would that be a difficulty for independent providers these days? Of course it would. Of course it would. So it's not a sort of a simple solution, but it is, we think, needs to be addressed that public funding currently is compensating for registration and regulation and inspections of registered services. As I say, we get about £1 million in from registered services, but we spend £10 million largely unregistered services. So we do offer a modest solution which will require changes to the regulations, but maybe not to the primary legislation. And we think maybe phased over time, thoughtfully, all of that. But there would be a solution that we could grow. I mean, RQA is not growing as an organisation, nor are many others, I'm certain. But the sectors are. Independent healthcare, private hospitals and private clinics are growing. We can't keep at pace with that, and the amount we charge them to register wouldn't look at it, you know. So sometimes people raise with us too about why are you slow at registering services? You know, what's the problem? The problem is registration and regulation and inspection is one task. 17 inspectors are aligned to 470 care homes. They're the same inspectors who register that care home. When the care home's changing their manager, or it's that same inspector. It's that same inspector who speaks to the families when they ring in to say, I have a concern, I have a problem. It's the same inspector who reviews the notifications about falls, medication. It's the same inspector who goes out on inspection. Registration, regulation, inspection is one task. So look, you know, there is a solution, but it would take long term, and it would mean a policy decision that registered services pay for regulation, whatever the cost is. And we're not talking millions, or, you know, we're not talking those scales, but it would offer a solution and very modestly address that issue of using the public purse to fund that. So, but while we have what we have, 10 million and 140 people, we will use intelligence, information, whatever you want to call it, to make the best judgments we can, put our efforts into the greatest risks. Last year, those 17 inspectors did 700 inspections of care homes. 700. They also registered, changed the managers, listened to families, all of that. And that's the reality. There's no point. Yes, if we had more, just like everybody else, we could do more. But we say modestly, we offer a solution in ours, a full cost recovery model.
Sorry, go on ahead, Christine, and then I'll...
No, I mean, I think, as I've said, the authority as the sort of body that's, well, it is the RQIA. We have set up a policy and legislation committee to actually look at the legislation, to look at things like how would we do a full cost recovery model? Technically, how would it work? And that work is going on. Brought in some outside expertise as well, but it's being channeled and progressed. And then we will present it to the department, because I think it's unfair to say to the department all the time, just give us more money. There isn't any more money, we know that. But if we can give to the department, well, actually, here's a proposal, here's a solution. It gives them something to work on and to think about. And I think it's better that it comes from us, because we have the exposure to the reality on the ground. We have the exposure to what's actually happening, to make those proposals actually real, rather than being something somebody's sat in a darkened room down the road in Castle Buildings and dreamt up. So that's what we're trying to do all along, is be real and produce stuff that is actually practical and could be done.
Yeah, thank you. I have Danny.
Thank you, Chair. A few issues just to start with the mental health issues that Orlia has raised there. So from my understanding of what you said, the mental health facilities just aren't regularly inspected, and you made the comparison with A&E's maternity services and wards. Those facilities are subject to inspection though, albeit not regularly.
And so is community mental health.
Right.
All services that are provided by the Health and Social Care Trusts could be, well, actually, to be pedantic about it, but you have to review first and so on, but yes, could be subject to inspection. None of them are subject to regular inspection. None of them. There are 3.6 inspectors assigned to that work for the whole of the trusts in Northern Ireland. In the recent times, the work they've concentrated on has largely been directed out of the public inquiries. So, for example, the review of outpatient services, we first carried it out in the Belfast Trust, neurology outpatient and all the high volume specialties there, rheumatology, all the ologies, I think, so to speak. We published that report a couple of years, or maybe 3 years ago, and the small group of inspectors we have are now out doing all of the trust outpatient services based on what we found there, like solo doctors, appraisal of medical staff, using the HSC quality standards as their framework. So while they're doing that, they're not inspecting an ED, or they're not inspecting, a maternity ward. The reviews are important because they generally, all that I can think of, cover the boundaries of the trusts. So when we're doing a review of maternity service, it's all trusts, and the recommendations and so on out of that would affect all trusts. But I'm not trying to, diminish the value of inspection. We would like to be doing more inspections. I think even at times when we're out with trusts, we're usually warmly welcomed, to be perfectly honest, and most people do understand, including senior managers and others, that regulation does play a good part in sort of safety and quality, and looks at a mirror in it. But it'd be wrong of us also to say to you or to the public that, we have a regular inspection programme of EDs, medical wards and community mental health services. We don't. But we do sporadically, based on a small amount of resource, sporadically do inspections. And one of those could very well be community mental health. But I'd be misleading people to say we could put in place a regular programme of inspection for community mental health. I'd be misleading. I'm hoping we could maybe do a review or an inspection, but it wouldn't be regular. But I really must emphasise, we must focus on the individual experience. A, because we must do, and B, there's learning out of that for the wider system.
Yes.
I
wanted to ask you about that. When you talked about the individual, and I appreciate when you say there's a wider body of knowledge that you can come from one case, from following one case. How does those one cases get referred to? Generally by family or by the patient themselves?
By family.
By family.
Family or carers.
Family or carers. So when there is generally an incident, then it becomes...
Not necessarily even an incident. Families will contact us where just a whole series of things have occurred, that over a period of time they've become concerned. And it's not exclusively families. Sometimes yourselves and other colleagues will contact us about out on their travels, as I would say, they've come across somebody or met somebody who's raised a concern with them. And we would say, would you, mind putting them in touch with us and so on. And I don't want to claim that we're doing hundreds of these cases. It's a few handfuls at any one time. But yes, it's mostly families, carers, maybe organisations acting as advocates, that type of source.
Could that expand into a wider inspection of a particular facility if you thought that there was an issue?
Definitely.
Yeah.
And actually, you encourage me to sort of say as quickly as I can, that's sort of largely what happened when I was mentioning earlier, we're doing an investigation. They all fall under the same banner, but we're doing an investigation of learning disability residential care. This particular home is at the focus of it, but we're looking at a couple of other homes by comparison. And largely that came because a number of individual cases had raised, and we began thinking, let's look at how that's been managed, for that home and others like it, because we're bound to find there's likely to be lessons here, not just for these 2 or 3 cases, but for the whole home and others in that locality maybe.
Can I ask about whistleblowing as well? I noticed that obviously you have a facility for people within who are working within services to contact you just about that. How often is that used, and does that generally, without obviously maybe going into any details, does that progress into wider inspections and wider issues being revealed?
Yes to the latter. I think for every one that we would receive, and last year received 103, and that was a similar number the previous year. And there's certain conditions, there's maybe twice as many as that people contact us but doesn't meet the definition, so to speak. There's loads of things around, well, you have to be a worker, for example. Sometimes people say, well, it's whistleblowing, but actually maybe they don't work in the health service, and so we still treat those as concerns and look into them. But in terms of whistleblowing for staff working in health and social care, independent sector and statutory, with 103, all of those will be looked into. Sometimes the individual doesn't want to be identified. That's fine. We don't say in those cases, well, let's not look into that then. We look into it. We may not have anybody we can go back to say, here's what happened. But in some cases we do. And I personally know of, think of a number of examples of what that whistleblowing led to inspections. Inspection's not the only thing. We can lift the phone as well and ask things. We can ask to be sent information. I mean, a regulator ringing you as a provider asking for something, I would imagine is a pretty big deal. So inspection isn't the only tool available to us. And increasingly we try to use other leverage, asking somebody to come to a meeting, asking them to send us information about something, speaking to somebody on the telephone, a provider, a staff. Inspection is probably at the upper end of the tools that you have available to you.
I wanted to go back just to A&Es. I know you had mentioned A&Es and the harm that's being created by overcrowding in A&Es. There was Dr. Russell McLaughlin, I don't know if you're aware of, I think he's the chair of the Royal College of Emergency Medicine, did a report about 2022, and he suggested that over 1,400 excess deaths had occurred in Northern Ireland in the year 2022 because of delays due to overcrowding in A&Es. Do you recognise that figure yourself? Do you think that's an appropriate level? And I know, having worked in A&Es, I know the pressures are intense for the staff, for the patients, and as you say, they've become wards. People are stuck in them, sometimes 2 wards worth of patients for extended periods of time. Do you think that's...
Look, each of us as organisations provide different perspectives on it. Dr. McLaughlin or Mr. McLaughlin and his colleagues have that perspective and that knowledge and that ability. That isn't our knowledge. Our knowledge is that we are able to contribute the regulatory view. I would suggest take all of those collectively. The Royal College of Nursing and others have been able to articulate professional staff's worries, concerns, anxieties, and absolute, beyond overwhelmed with things. We would say take all of them collectively. It's not about me or Christine having the knowledge of Mr. McLaughlin's work, but we can say from our point of view, we found when we did that inspection, all 5 standards were breached. So I would suggest it's look at it all collectively. Everybody's saying similar things, but they're coming at it from different perspectives, and each of them are valid, I would suggest.
Yes, I certainly wouldn't want to question Dr. McLaughlin's figure work. I mean, I'm not competent to do that. None of us would be. But I think it is important that all those different perspectives, I mean, the perspectives from the nurses about the safe staffing levels and, what a nurse can actually physically be expected to do, what the doctors are saying, what we're saying, all of that needs to be put together. And I think we need to have a sort of intelligent, grown-up conversation about what it means, and what then we go on to do about it. Because otherwise we'll just keep on going round and round in circles, telling each other how dreadful it is, and there won't be any sort of forward motion.
Actually, that was Dr. Wilkins's point, that that was 2022, and if we didn't do anything, it would only get worse. And obviously, we are further along now. So do you think there's a gap then? There's a gap in the knowledge, or?
I think there's a gap in the connectedness of the system is what it is. And then it is around the decision making and the leadership, and those are very difficult things to do. I think there's no ducking it. Some of the decisions that do need to be taken are very hard decisions to take, which is why I think we need to have the grown-up conversation, because in my view, we must not disrespect the ordinary members of the public. They experience this day and daily. I mean, it's ordinary members of the public who are going to sit in an A&E for 24 hours. They're experiencing it, they know. And I think we need to start opening up, part of the candor piece, and being open about what the realities are, not selling them sort of false messages that, just a bit more money would solve it. It won't. You look at workforce, how long does it take to train a nurse? How long does it take to train a doctor? And I don't think we can sort of keep importing nurses and doctors from abroad, especially not when our own are leaving in droves. So I think that we do need somehow to get under the skin and start really discussing this as a society and saying, what are we going to do and how are we going to do it, and taking it forward like that. I don't think there's any alternative. So I would agree with Russell. I think that we just have to have that kind of discussion and then put our big girl pants on and take a few decisions.
Thank you.
Okay, Danny. I have Nuala. Were you looking in? Yeah, and just before Nuala, if you come in, we're over time, so I have Nuala, Linda, and Diane. And if we can try and keep it as brief as possible, because we have 2 more briefings.
Yes.
Go on ahead, Nuala.
Hello, thank you. Thank you very much for coming here today. I'm sorry I can't be there in person, but I have been listening to all of the questions and the presentation. I think it's important that you are here today with the committee, and the committee has previously agreed that as part of our work, we will do ongoing sessions around the various reviews and inquiries that are taking place. So I don't doubt that we will see you back here again at some point. I first of all just want to touch on the Muckamore inquiry in particular, and obviously you had said there's current processes and they have to be allowed to take place, and I respect that the inquiry is currently ongoing at the RQIA. You yourselves have been given evidence to the inquiry, but there are some things that have been coming out of that perhaps sit outside the remit of the inquiry, and there has been some information that has come to light regarding just allegations made before it all became public, and it just leads me to a question that has come up whenever we meet with other organisations, with other people regarding the Michael Watts Deceased Patients Review, etc. And it's about this issue of the independence of RQIA and actual powers. And I just want to get your view on where you see where the powers could actually be strengthened within yourselves, and what benefit it could be made. I know in your briefing you kind of were likened to the Human Rights Commission, but if you can provide an assessment of where you think the powers could be strengthened for the RQIA yourselves.
Right, if I lead off on that. I think First of all, the RQIA, Regulation and Quality Improvement Authority, was established actually by this body, by the Assembly. I know it eventually became put into law over in Westminster because the Assembly had fallen over for a bit, but that legislation was debated here, born here, it comes from here, and that legislation establishes RQIA as an independent entity. So we are an authority consisting chair, me, and up to 12 members. So it's a totally different construct from the trusts. I think something I need to get across is that we are the authority, the body of us. Briege is our chief executive, to whom we as the authority delegate responsibility to carry on things day to day. But ultimately the buck stops with us, stops with me. I'm accountable through the Permanent Secretary of the Department of Health to the Minister. So that, I think, is a different construct from the trusts, where they're really delivery arms of the department very directly, especially now that the board, HSCB, has been subsumed into the department. So it is a different construct. Speaking entirely personally, as an authority, I'm absolutely determined that we will be independent of the department and of anybody else who tries to put wrongful pressure on us to say something or do something that isn't based on the evidence we get from our inspections and our activities. Not on my watch, if you see what I mean. It does come with tensions. I mean, the perception undoubtedly is that we get the vast majority of our funding from the department. And, who pays the piper calls the tune. And there is a bit of truth in that. So I'm not denying that the relationship with the department can have tensions in it. Solution to that is actually what Briege has been talking about, full cost recovery. If we had more money coming into us independently of the department, it would do two things. One, it would stop the public purse subsidising the independent sector, which is really the net effect. And the other is that it would give a lot more reassurance about our independence. And I think both of those are very desirable things to have. But I just want to make it absolutely clear that as far as I'm concerned, the authority is independent of the department. Obviously, we have to be diplomatic with the department, we have to keep the relationship going, but there does have to be that healthy tension. And I mean, I've worked extremely hard over the last 3-4 years to try and make sure that we have got that relationship right, along with my fellow colleagues on the authority, all of whom I have to say, they're people of great integrity and repute, every single one of them. I don't think you'd have any hesitation in trusting their integrity, their professionalism.
Thank you. And as I said, I think we will come back again to the Muckamore issue because it is live. I think actually this today and yesterday potentially the evidence was
Yes.
ongoing from RQIA. So I'm sure that we will no doubt come back to that. I want to move just back to the Michael Watts deceased patient review and understand, Briege, where you come from when you say that the next steps are essentially up to the department. We have been hearing as a committee from families of the patients quite a lot. There's a lot of correspondence because these families have been waiting for quite a long time, so naturally they are frustrated with the delays, but I understand it may lie with the department as to how many and when next, but the significant small number of the actual reviews is so that have taken place of the deceased patients is just so disheartening. And there has been communication made to Assembly members that there's been a lack of communication or a breakdown in communication between RQIA and families. So I'm not sure if you can give us any insight into that or how we can actually re-establish relationships that whilst next step up to the department, there's still, is it just 1% of patients have been reviewed?
Basis. I'm very disheartened to hear and I accept what you say, that somehow families feel the relationship with RQIA is broken down. Please, for those who might talk to you, ask them to contact me, speak with me. I suppose we're talking about two different groups. There's many different groups, but there's the 44 families who we've already engaged with, and we continue to contact them. I was speaking to one of the families last week. Some of them still engage with us. In fact, one of the family members thoughtfully and so helpfully recorded a small video that we're using now in preparation should there be a further phase, so that a family member can explain directly to families what it has meant for their family and how difficult it was. So we have ongoing relationship with families, but I do appreciate that many of the families we've already engaged with are very disappointed in the findings of their individual report, and others out there still expecting and hoping to be involved in a further phase. RQIA provide as much information as we can to families, but I cannot answer their question about if and when another phase would happen. But I did write to the 18 families who've come to join us in the last recent times. I wrote to them the last few days. We have a free phone telephone number, an 0800 number for anyone who's interested in the neurology review. We have an email address. We have a family liaison team. All I can ask you is, would you please encourage people to use it? I also offered to meet with the neurology patient platform through the Patient Land Council recently. Now, just on that occasion, there wasn't sufficient interest, bar one family were interested, and I met with them. But the offer is open there to meet with anyone who has a concern with, and I'm so sorry to hear that. I apologise to those who feel we've let them down, because that couldn't be further from what we hope to do.
And thank you for that. And I think that we can feed that back for sure. Thanks. And I just, before I finish, wanted to say thanks for the recent contact that we've had, Breach, with the North Belfast care home. I think it is an example of which the RQIA has to and must, upon inspections, ensure that the recommendations are actually acted upon. It was distressing for families, but ultimately the care of loved ones is at the heart of that. And do you have a view regarding CCTV within care homes, mandatory CCTV within care homes, albeit of course you can't do that in private. There are those issues in private areas, because the Adult Safeguarding Bill, of course, is coming before the Assembly soon.
Well, in a way, all I can do is endorse what you've just said. Where care homes and other establishments, and particularly care homes, choose to use CCTV in the public areas, they must do so in engagement with families and residents. And we have guidance produced on our website, and happy to speak to anybody should they want any advice and support on it. We don't hold a particular view. It should always be by consent. It's not about saying there should be, there shouldn't be. It should be by consent, involvement, make decisions that people are comfortable with. And as you say, the Adult Protection Bill is very likely to cross into this area in the coming time. So we don't have a view on it as long as it's done by consent and involvement.
Okay, thank you.
Linda?
Thank you, Chair, and thank you to both Breach and Christine. You referred to the inspection around learning disability in the Belfast and South Eastern Trust, I think it is. And I'm just wondering, you'd said, I think in the next couple of weeks you might be back in touch. I know I had raised concerns around this, but I'm not going to name salaries just because I don't think it's helpful. But you had been in contact with me previously around that. So are you going to be speaking to families or going back to families in the next short while in relation to that?
Yes, there's letters going out to particular families in a number of homes that are part of that review, and we'll be inviting them to meet with, not with myself on this occasion, but a senior colleague of mine and a support member staff in our premises in the coming weeks.
That's really helpful, thank you. And I appreciate that, because I think that was really their only concern. This is happening, but what happens next? So I do appreciate that. The report that you have said from the working group that's going to go to the department around perhaps that new funding model and legislation in general, is that something that the committee could also get when it goes to the department, or would it have to go to the department first? I mean, you can come back to us on that if you don't know.
Come back to you on that.
Yeah,
I mean,
that's fair enough.
I'm all for openness,
Yeah.
but the department might want an opportunity to
Yeah.
actually mull it first.
And I've no problem with that, but if you can come back to us, I think it would certainly be helpful. And then just in relation to Muckamore, I'm not actually going to ask any questions. Everything else that I wanted to ask has been covered, and so I appreciate that. But if I can just put on the record our recognition of Geraldine O'Hagan, who passed away. Geraldine was an amazing advocate for the residents, the patients of Muckamore and their families. And she was somebody who I worked closely with on behalf of a number of families, and I think those families would appreciate her being recognised in the work that she did, and right up until the day she died.
Yes.
Yeah, thank you, Linda. Thanks very much. And Diane, last but not least. That's you now, I think.
Yes, thank you. It's been a really interesting session. Breege, first of all, can I ask you, you spent some time, and forgive me if I've got this wrong, describing the relationship between trusts and facilities run by the trusts, and the way that you would inspect them or not inspect them or not regularly inspect them. And I'm not gonna. I don't want you to. I mean, I don't want to put you in a difficult position in relation to Muckamore, but I'm really interested in, when you do an inspection, how much notice and what the trusts do with the outworkings of that inspection. As far as I am aware, you held early meetings with the Belfast Trust over Muckamore before much of what we now know that happened became public. And you then did further work around Muckamore as late as 2022-23, where you were still highlighting concerns. Do trusts take you seriously, or what is the legal position that you have in enforcing trusts to actually take notice of the issues that you are highlighting and trying to sort out for patients? Because it seems to me in this case that while concerns were raised, trusts still did not adequately address the concerns.
I'm cautious not straying too much into Muckamore specifically, but maybe, Dan, may I say a couple of questions first of all. How much notice do we give of inspections? Virtually all of our inspections are non-announced. So we don't give notification. I would sign off a letter a few days beforehand. We will have planned the inspections, don't get me wrong, and I will send out a letter the morning of the inspection to the chief executive or senior officers and let them know the staff will be arriving at 8 o'clock or 9 o'clock or whatever time it might be, and that would apply to Muckamore. Muckamore's a little different, and I wish I had more time to say, but when I was explaining to other colleagues that we don't regularly inspect community mental health services and maternity wards and so on, sometimes the public has said to me, why do you inspect Muckamore then? Because it's run by the trust. And you said you don't do that. Because of the mental health order. It's different. So is Lakeview, so is Bluestone, so is anywhere where anyone is detained falls under the mental health order. So if we had more time, we could explain it's not just the inquiry into individual cases, but actually there's a duty under the mental health order for RQIA to visit and interview in private, I think it says, individuals who are detained under mental health legislation. But of course, when we're there, we don't just speak to people who are detained, we speak to people who are there on a voluntary basis as well. But it's just to explain a little bit about why Muckamore is different and why we seem to be regularly inspecting Muckamore when I've just said we don't regularly inspect because of the mental health order. They're not notified. Now occasionally you might notify somebody to say I'm coming because you want somebody in particular to be there that day. But 99.99 they're not. You'll notice in our annual report there's a good chunk that are notified. Those are mostly to dental practices because you want to have the key partners in that day. But care homes, trusts, any of that, not notified. Do they take us seriously? I believe they do. when we find things, and we have found things and had to report on them repeatedly, not just around Muckmore, which is in the public domain, but others. We have some authority. We bring the senior officer, quite often the chief executive, to a serious concerns meeting. Ultimately, we can serve what's called an improvement notice on that organisation. That immediately, within 3 days, I think it is, goes on our website. It attracts a lot of public attention from yourselves, from others. I do believe trusts take it very seriously. It does mean they have to rally the evidence and resources to begin to address those. But does that mean they always do so successfully? No, and the evidence of repeat inspections can demonstrate that. The final, unlike registered services where you can set conditions on no more new admissions, or ultimately, as Linda was referring to, maybe, or others referring to, maybe care homes where you can actually, not without a great deal of thought, but you could ultimately take their licence away, so to speak, and that closes that home. That does not happen with any HSC services, not community mental health wards or Muckamore or anywhere like that, because they are all HSC. So the optimum leverage we have is bringing people in, showing them our reports, asking them to take actions. Not satisfied with that, we issue an improvement notice. That demands action. If it's not taken, the next step is over to the Department of Health, because the direct responsibility between the trust is to the department. There are no more powers to RQIA in that regard, and Christine's already explained that's because the construct of the legislation and the way things are, that's why it's like that. But I do, Diane, find trusts do take it seriously. Chief executives, when we send out a letter about a serious concern, most often will be at that meeting. Their senior directors will be there. Others, they do take it very seriously. Does it always mean everything is resolved? No.
Yeah, I think that the saddest thing in relation to Muckamore, and I'm not asking you to comment, I will, is that repeated inspections still find repeated failures. And I think that is an incredibly sad thing for people who were very, very vulnerable. And I just, I understand what you're saying in relation to the mental health order, but it seems to me that there is a huge failing in the system, and I suppose the worry is that this could be repeated because of the failing in the system. Can I just take you on to a couple of other things that I think are important? I'm interested in your full cost recovery model. I think in a time when we are looking at finances in an extremely difficult financial situation, that is an interesting model that you're proposing, and I think that is important. I also had meetings recently with these people were actually people who there's a number of clinics and so on that have been set up in the high street recently in relation to ear waxing and so on. None of these are regulated by RQIA. What must you do, and how are they going to be brought into a system of regulation? Because what the point that was made to me that this is interfering with really sensitive, invasive procedures in terms of earwaxing, and some people who are doing this mightn't have had more than a couple of days in-house training.
Services that are delivered in the high street, and I know we're just using that as a way of trying to make it, they fall outside the current regulation. What would bring them inside it? A change in the legislation. The 2003 order is what should cover that, but in it, because it was probably written several years before that again, the legislation only requires services on the high street that are provided by medical staff. So you have to be a qualified doctor. If you're running a service, and there's plenty of services nowadays where we're run by other types of professionals, then it doesn't fall to need to register with us. So and I've modestly highlighted in the introduction, there are several services fall outside that. The tourism, healthcare tourism, dental clinics pop up in hotels and so on. Online services where you and I can log on, get advice, maybe even get medication and so on. where those sorts of services fall outside the jurisdiction of Northern Ireland, maybe being provided remotely, there's debate about whether the current legislation, the 2003 order, actually allows for that, because it tends to focus on what's provided, like from physical premises. There's a debate going on, a discussion. We, as Christine says, our committee, legal committee, is often drilling into this to see is there any variation on it. But there's a lot of services now in a modern healthcare model that they're not regulated at all, Diane, and it would need legislative change to enable them to be brought into that model.
Aesthetics is a big one.
Yes.
So it's one we've had concerns with.
Yes, very much so.
Different kinds of therapies and so on.
Yeah. Diane, and I'm conscious of time. Have you anything else you wanted to ask just quickly?
No, I will leave it there, Chair, but with the proviso that we are an hour and a half into the committee, and apart from the last 5 minutes, only 2 parties have been allowed to speak.
Well, that's not deliberate. Diane, if you have further questions, I'm happy enough. There's only 4 of us in the room here.
I will leave it there, but I do think that that's worth some
Well, if you have any further questions you wish to add, I'm happy to take them. I'm just reminding, because we've 2 more briefings, and I want to make sure everybody gets an opportunity.
I said that's fine for now.
Okay.
But I do think something that I would like to have a conversation about.
No problem, and I just take people as they indicate, so that's how I've always done it. But thank you both. As you said, there's so much that we would like to ask, and as others have said, I'm sure you will be back to the committee on more specific issues, and we'll hopefully have more time as well. So appreciate your time.
Thank you all very much indeed.
Thank
you.
Okay, members. As I say, we are very tight for time, but I know that's a very important briefing, so try to give as much as possible. Our next briefing is the Allied Health Professions Federation Northern Ireland in relation to the role of health professionals in healthcare transformation and modernisation. If I could refer members to page 25 of your pack. A briefing paper has been provided, so just give a wee minute. You're all very welcome, and apologies. I really do appreciate your patience. It's quite a hefty agenda today, so we do appreciate we have run well over time. In attendance today we have Cora Regan, who's the co-chair of the Allied Health Professions Federation and National Officer of the Society of Radiographers, Ruth Sedgwick, Head of Northern Ireland Office, Royal College of Speech and Language Therapists, Cleena McCarney, Policy and Public Affairs Lead Northern Ireland for the Royal College of Occupational Therapists, Tom Sullivan, Policy and Public Affairs Manager Northern Ireland for the Chartered Society of Physiotherapy, and Dr Anne Monaghan, Policy and Public Affairs Officer Northern Ireland for the Royal College of Podiatry. So you're all very welcome, and we do have probably about a half an hour, as you'll appreciate, but briefing papers provided, so if you want to make a few opening remarks, and then I'll open it up to members. Thank you.
Good afternoon, Chair. We would like to thank you and the committee for the opportunity to present today on the challenges facing allied health professions in Northern Ireland, our priorities, and how we can contribute to solving the pressing issues within our health service. AHP Federation NI provide independent leadership and collective representation on key issues that impacts its members' professions in Northern Ireland. There are 7,693 people registered with the HCPC as AHPs in Northern Ireland, with approximately 5,500 working for the 5 health and social care trusts. Collectively, AHPs account for the second largest group of health and social care staff. And it is notable, however, that despite a marked rise of over 1,500 HCPC registered AHPs since 2020, there are actually 250 less working within the HSE in Northern Ireland. The expertise, autonomy and innovative approach of AHPs make them critical to the ongoing reform and modernisation of healthcare services. Unfortunately, this is not the first time that the AHP Federation have addressed the Health Committee. Indeed, a delegation provided evidence in February 2020, and whilst we don't want to go over old ground today, it's important to note that much of what was raised then has not been resolved 4 years later. Whilst we acknowledge that since 2020 we've come through a global pandemic and the unprecedented system pressures that the pandemic intensified, it's important that we do not use the pandemic as an excuse for inaction. Allied health professions are integral to the healthcare system, yet they face several significant challenges. There's a growing demand for services, yet we face shortages in key service delivery areas such as diagnostics, mental health, cancer and stroke services. These shortages are exacerbated by recruitment and retention difficulties, and indeed some vacancy rates in AHP disciplines are as high as 36%. Limited and short-term funding affects service delivery, leading to longer waiting times and reduced patient access to diagnosis and necessary therapies. These can compromise patient outcomes and increase long-term healthcare costs. Patients are waiting too long, presenting too late, and the moral injury experienced by those staff working in services cannot be underestimated. Continuous professional development is crucial for AHPs to stay updated with the latest practices and technologies. However, opportunities for training and development are often limited by both time, financial constraint, as well as the obvious prioritisation of service delivery. Effective collaboration between AHPs and other healthcare professionals is essential for holistic patient care. However, there are often barriers to integrated working, including siloed services, communication gaps, and preconceptions or misconceptions around role creep. To address these challenges, AHPs have identified several key priorities: implementing strategic workforce planning to address shortages, improving recruitment and retention strategies, and ensuring access to training and career progression opportunity. Previous workforce reviews were completed for the majority of AHP disciplines in 2018-19 and were published in May 2022. However, the recommendations of these workforce reviews still remains undelivered. Advocating for increased or repurposed funding to support service reconfiguration and the expansion of AHP services to reduce waiting times and improve patient access to care. Currently, levels of demand for services remains unfunded, and this gap must be urgently addressed. Ensuring AHPs have access to continuous professional development opportunities will maintain high standards of care and adapt to evolving healthcare needs. And promoting integrated care models that facilitates better collaboration between AHPs and other healthcare providers, ensuring a more coordinated and patient-centred approach to care. So this committee has heard recent submissions from many other stakeholders within the wider healthcare system, and allied health professionals can provide several solutions to the broader challenges facing our health service. AHPs play a critical role in prevention and early intervention, helping to reduce hospital admissions and the burden on acute services. For example, physiotherapists can manage chronic conditions effectively, preventing exacerbations that lead to hospital stays. Diagnostic radiographers can report a range of modalities, including plain film, ultrasound, CT and MRI, and therefore facilitate timely diagnosis and discharge from both secondary care and pressurised ED departments. Effective rehabilitation provided by AHPs can significantly improve patient outcomes and reduce readmission rates. This is particularly important for patients suffering from surgery, stroke or injury. AHPs also provide essential services in mental health care, offering therapeutic interventions that support mental well-being and recovery. They empower patients through education and self-management strategies, enabling them to take control of their health and reduce reliance on healthcare services. We are at the forefront of healthcare innovation, contributing to research and the development of new treatment modalities and technologies that can improve patient care and system efficiency as well. However, Northern Ireland as a region is slow to adopt proven service development. One such example is that Northern Ireland is the only region in the UK not to have podiatric surgery in place. Another example is that the creative therapies of drama, art and music therapy are not utilised within the HSC. Unfortunately, there are many other such examples. The immediate asks from the AHP Federation in Northern Ireland are an increase to the undergraduate AHP numbers in line with recommendations of the workforce reviews as an absolute minimum. Investment in the practice education and placement support required for these increased numbers. Investment in the development of apprenticeships or earn as you learn programmes across the AHP disciplines. Development of graduate level entry and master's programmes in line with the rest of the UK. Development of advanced practice programmes for AHPs to address the needs of the workforce and to prevent staff having to travel to GB and the associated cost that incurs to the system. and expansion of the first point of contact services across the AHP disciplines. While our asks do involve some form of investment, we believe that the healthcare system itself needs to be smarter with how funding across the system is utilised. In conclusion, AHPs are vital to the functioning and improvement of our health service. Addressing the challenges they face and supporting their priorities will not only enhance their ability to deliver high quality care, but also contribute significantly to the sustainability and efficiency of the health service. Thank you once again for the opportunity to speak, and I also want to pass on thanks on behalf of our paramedic colleagues who wanted to thank the committee for your help in achieving cipher codes for paramedic prescribers. The Federation now look forward to your questions and to working together to support our AHPs and improve healthcare outcomes for all in Northern Ireland.
Thank you, Cora. That's been very comprehensive, very useful, and it adds to what we've already read in the briefing. I just have one or two questions, and then I'll open up to others, because we did have some discussion around this at one of the recent all-party groups as well. And you did mention around just how important the role of AHPs are, particularly for prevention and early intervention. And coming from my own background, I would have worked closely with reablement teams, rehab teams, and I see just how well that can work if people get the right care at the right time from the right team, and it can prevent longer term domiciliary care home placements, and longer stays in hospital. So absolutely agree with what you've said. Just in relation, because something I am very interested in is the point around apprenticeships and fully utilising the skills, the knowledge, the expertise that the wide range of AHPs and when I looked at the number of members, you have 13 members that you represent. That shows the vast range of skills and expertise that you represent as a body as well. So in terms of the level of places for apprenticeships, what do you think, or can you put a figure on it that would help to satisfy the current and future demand, just to support the existing issues that we're seeing?
Well, at the moment we have no apprenticeship schemes across the HSC. We have an untapped resource in our support workers for all AHP disciplines. They don't have a formal career pathway, but many of them, if they had the opportunity, would like to move towards that registered practitioner position, but there is no facility currently to do that. The trusts continue to pay the apprenticeship levy every year with no return on that investment.
It's how long is a piece of string, really? Because even on the high street, and we were talking about it in the last briefing, there are a number of people who have set up clinics as foot practitioners, dealing with, corns or warts or things like that, who would love the opportunity to go on to be an apprentice podiatrist, for example, or people who would love to be apprentice, OTs or apprentice, just to have a different route to entry than what currently exists. And they've been in England and other parts of the UK for years and years. And again, we're lagging behind in Northern Ireland. And it's like the podiatric surgery that Cora mentioned as well. We've podiatric surgeons in Northern Ireland that fly to England, Scotland, and Wales to carry out foot surgery every week. And yet they could be working in Northern Ireland in community settings in day clinics, because a lot of the foot surgery can be carried out in a community setting in a day clinic, and there'd be no need for hospital stays, freeing up beds and things like that. So we're here today to put forward suggestions for reform and improvement. We don't want to just have a moan. We know what the situation is, but we all have suggestions for the professions to how we can improve and reform the services.
Can I just add, Chair? About 2 years ago, we carried out an exercise with support workers and physiotherapy across all the trusts. We have about 200, and we estimate that in the responses that we got, about 50 of those would welcome the opportunity to progress to registration through an apprenticeship scheme. Now, the other issue around that is that these are people who are embedded in their communities, who are working as support workers, but they have no pathway to progress. Those are people who are going to stay in their communities. They're not going to go. They've been there for years. They're well established within those communities, but they have no pathway to progress. So in terms of investing in stabilising the workforce, those are people who are going to be there for many years to come, but have no pathway to progress.
Yeah, no, absolutely. Sorry, go on ahead.
No, sorry, Chair, if I could just pick up on that as well. And we had this conversation just this week with the Health Minister too, and I think it's important to just set it in context. So there is no pathway other than university into the vast majority of AHP professions. So apprenticeships would be massively helpful. We've seen huge success in England with brilliant OT assistants, in my case, being able to qualify. They don't need to leave their post. They don't need to go to university for 3 years, and all of the challenges that presents financially, logistically. So there's huge opportunities there. In terms of, as Anne said, it's difficult to put a figure around it. For occupational therapy, last year we had 75 commission places from the Department of Health, and there were 859 applicants, which gives me and hopefully you a lot of hope as well, that despite all the difficulty and the challenge we have, people are still really, really interested in joining the AHP workforce. Those are the OT figures, but I know that the similar right across the board. So people are interested in joining the health service, but there are far too many barriers, and we need to make it easier for them.
Yeah, and I suppose that the difficulty we have in putting a figure on it is that the vacancy rates even that are reported across Northern Ireland for the AHP professions are based on previous funding levels. They're not based on the current levels of demand and the current staffing that is required for that increased demand as well. So actually the vacancy rates that you see reported don't take into account your long-term absences. They are permanent whole-time equivalents. They don't really reflect the gaps that there are actually out there in the workforce. And apprenticeships definitely would go a way towards helping with that workforce crisis that all disciplines are in, but it's only one part of it as well. We do need the implementation of those workforce review recommendations as a matter of urgency, as a minimum, as they say, in terms of undergraduate places, master's level entry, etc. That all needs to be taken into account as well.
Yeah, no, and your point on that, we have been raising that around vacancy rates and what's recorded for across different sectors in the health service, because what we find is that generally it's what's being recruited for. That's not always the true figure, and we have been asking further questions on that right across the board. I suppose you've kind of answered where I was going to go next in terms of recruitment and retention, and I really take the point, Tom, that if someone has an opportunity to do that career progression in something they really love, they've been doing for a long time, and it's really just building their skills, bringing them up to that, to go on to register. I think it's so important. It's available in other areas, in social work anyway. I know that's definitely one you can do it in, and I think that the benefits are very evident. So anything that we can do to try and push that forward. And just very quickly, you mentioned, Cliona, that you have already met the Minister this week, the new Minister. And I know in your briefing paper you had said that the previous Minister, Robin Swan, had said he was going to engage with the Chief AHP Officer on some of the issues raised in terms of transformation. Do you get the sense from Minister Nesbitt that he understands the huge potential we have here in terms of transformation for our health service?
Yes, certainly when we met with him, he did take on board. He was particularly interested around the apprenticeship points that we made, and the fact that they still haven't been progressed, even though the trusts have been paying that apprenticeship levy for quite some time. I think he did after our meeting, maybe not necessarily before, but after our meeting, I think he did understand the concerns that we have. But it's not only the concerns; it's the actual opportunities that we can provide. Our previous session, with RQIA, was all about doctors and nurses. AHPs don't really seem to get the same attention and don't seem to get taken as seriously as other disciplines would. And we have got such a huge, wide variety of different disciplines that have got so much to offer.
We meet regularly with the Chief Allied Health Professions Officer, and she has just put a paper forward for transformation funding to roll out first point of contact services beyond. So physios work very well, so to include OTs, SLTs, podiatrists, other services. So that would be people again working in communities in the primary care, so that so much then doesn't have to go to secondary care, so it takes the burden off our hospitals. It'll be really useful for the committee to hear from, you know, the CAPO about that and to support that paper, because it would be, you know, hugely transformative for all the services, but also for AHPs as well to be involved at that level, have more opportunity.
Yeah.
Could I just pick up briefly, Chair, on the meeting with the Minister? I'm conscious you probably want to move on. Cora and I met with the Minister yesterday on behalf of the Federation, and we had a really helpful discussion. And I think that's the key point that we want to stress to all of you today as well, and the point that we made to the Minister. We are cognizant of the financial challenges. We understand that everybody's facing a lot of difficulties. There isn't an unlimited supply of money, and we're not saying invest in AHPs for the sake of it. We're asking to invest in AHPs because we can be a big part of the solution to the challenges that you hear about day and daily, that the Minister hears about day and daily. So things like keeping people safe and well at home, getting people discharged quickly if they do need to go to hospital, taking pressure off general practice, supporting people in those big system pieces like mental health, cancer and stroke. So AHPs are key to all of that, and we want to get some support so our members can better be involved in those kind of things, and that's our key message.
Can I just add, Chair, that since the Minister has come back, one of the things that the CAPO did with his consent was to re-establish the Advisory Committee for Allied Health Professions, which had been moribund since 2012. So that has now started to work. One of the priorities for that Advisory Committee, which is chaired by the Chief Allied Health Professions Officer, is to look at those workforce reviews, and to look at implementation plans for taking those forward. One of the other responsibilities for that Advisory Committee is to look at developing a model or vision for community rehabilitation services in Northern Ireland. And that will include, again, our professions, but also third sector organisations who are part of that wider Community Rehab Alliance, which is looking at how we can improve those community services that are there to provide the services for people who need it in the community, to keep people out of the most expensive parts of the system and secondary care in A&E, for example, that we read about every day. So one of the responsibilities of that Advisory Committee is to take forward that and look at how we develop that model in Northern Ireland. What I would also suggest, Chair, is that with the development of our integrated care system and the regional forum that will sort of coordinate all of the integrated area partnership boards, that there needs to be a strong voice for the Chief Allied Health Professions Officer on that regional forum to ensure that there's a really strong focus for those boards around the development of community rehabilitation services.
Okay, well, thank you for that. I have Linda.
You'll be glad to hear you've answered most of my questions. But I suppose I'm just interested to hear, I think the Chair is right, one of the issues that we have been, I suppose, repeatedly raising is that issue about, you know, vacancies is only what we're recruiting for. It absolutely is not reflective right across the board. It is not reflective, and I think maybe, Chair, maybe we should be writing to the department and asking them why they are giving us those vacancy rates across the board for all of the professions, rather than giving us what they actually need, which is what PSNI, and I've raised this before, are doing. They're telling us what they actually need, not what they have, because they know what they need, and I don't see why the department can't do the same for us. Can I just ask one quick question? The barrier. What is the barrier, or who is the barrier to the apprenticeships? I'm a big advocate for apprenticeships everywhere. I just think apprenticeships should be everywhere, in every single department, every single part of our community and our workforce. But I understand that it's not suitable for everywhere. But I'm just wondering, what is the barrier? Because you said that the Minister said, like, you know, the trusts are paying this levy, and why has it not been implemented? Well, I would have thought it was a departmental decision, so it hasn't been implemented because the department hasn't implemented, I'm assuming.
I think I believe it's a problem of where the funding lies. It lies with the Department for the Economy, and doesn't lie within the Department of Health. So
we'd suggest that two departments start talking to one another about how we can free up the money, but because it's cross-departmental, there seems to be a blockage there, which is again an area maybe the committee could help with.
I would add that there was a motion that was put forward by the Economy Minister in March looking at apprenticeships, and there was a recognition from the Minister for the Economy that there needed to be closer coordination between the Department of Health and the Department for the Economy around how apprenticeships for nursing, but he also mentioned other healthcare professions should be taken forward. So I would imagine that there's probably ongoing dialogue between the two departments to try and progress that.
Maybe we can ask for an update.
Yeah,
on that actually covered. I've lots of other things. We are time constrained, and to be fair, you and I both know the issues it is that we have lots of people applying to be allied health professionals. Unfortunately, a lot of them are finding that they're having to go into, I'm not saying wanting to go into the private sector, that's where they're going because they can't deliver for their patients. Without going into the private sector, they're actually dealing with parents who are begging, saying, please, my child needs speech and language, my family member needs physio, can you please help me? So I know that they're being forced in a lot of cases into the private sector.
And can I just come in and absolutely, that's one of the issues in terms of, and I know Cora quoted the figures, but that we do really have an issue with retention at the minute, with the staff in the NHS. And Cora had mentioned the term as well, the moral injury, but that it's real of not being able to provide the service that they know that child or that adult needs and deserves. That they're not able to do that. And also, there's a lot of talk earlier today about risk, and it's about our AHPs carrying those risks and taking them home with them, and the mental health challenges. And we know that, we're seeing people retire early or leaving to go into private practice because they're able to actually do what they were trained to do. Our staff are so stretched beyond capacity. And we only need to look at the likes of the SEN challenges, and I know that you'll have heard that constantly, and I also know that sits with the Department of Education. A lot of it does, yes. However, the AHP staff sit with the Department of Health, and what happens, or what's not happening, is there's not great communication between the two departments. From our perspective, there are new these SPIMs, so the new specialist placements in mainstream that are coming up. I think maybe around 100, opening in September. And these children are going to need physio, OT, speech and language, and there is no additional funding being given to health, to the AHPs to deliver that. So what is happening is that our members are just getting every year stretched further and further. And a really real example, I suppose, of that is just an SLT said to me last year that when she started her schools post, she was over, in 2012, she was over 20 schools. And I thought, oh my gosh, that's quite a lot, 20 schools. And in 2023, she was over 62 schools. It's not sustainable. And so our workforce is really, honestly, they are on their knees and they're trying to provide the best safe service that they can. But they will, and some of them are leaving because we do not have enough staff to allow them to do what they need to do.
Can I just say, I'm glad you raised that, Ruth, because it is something that we have raised before, is that issue of health not working with education around special educational needs. I mean, it is something that has thankfully, in some senses, come to the fore in the last period of time in terms of support from this Assembly and from the ministers. But it certainly is not getting anywhere near what it needs. We haven't got to that point. The recognition is there, but we haven't got to the point of the funding, and I do think it is something that we need as a committee to focus on around the special educational needs and those children that need those services in the schools.
I think as well, just very briefly, Chair, if I may, I think we obviously just discussed a blockage with apprenticeships in the Department for Economy. Education is another example. Obviously, OTs in Northern Ireland have a statutory responsibility for housing, which links in the Department for Community. So I know discussions are ongoing about a programme for government and whether that's going to be an outcomes framework or how that's going to work. So I think greater collaboration right across the public sector needs to happen, and we'd really welcome any support or influence that you could give to that, because ultimately people don't exist in isolation, and we need to be looking at how we can provide that whole person holistic care, and that really is relevant to all departments. Justice is another one I know SLT colleagues have been working closely with, so it really is right across the board. So welcome any support you can give with that.
Yeah, thank you. Danny?
Thank you, Chair. Chair, I've had the privilege of working with a lot of AHPs throughout my career, and I know the value that you bring to the health service, and I know the pressures that your members are under, and it is absolutely intense. Absolutely understand the moral injury as well, and the pressure of going home and not being able to deliver the service that your patients require is horrendous. So I do get that. I wanted to go back just to the apprenticeship. Certainly the model that where you have student nurses working for the Open University, where the trusts do fund student nurses through the Open University programme, generally nursing assistants who then apply to the trust for an Open University programme. Is there any talk of expanding that towards the likes of physios, OTs or speech and language?
Not that I'm aware of, but and that's part of the issue that we want to raise, is that AHPs seem to come third in the race for everything. First you've doctors, then you've nurses, and then AHPs, come across the line third. Now there are assistants working, at various levels across the health service, as you'll know. But I mean, we think there needs to be a scoping exercise done, for reform across the whole health service, looking at ways, people other than doctors and nurses can assist with waiting lists. I mean, a podiatrist, if they were a first point of contact podiatrist in a GP practice, can free up a doctor, 80 appointments per week, which is a huge amount of time. And we just think this needs to be looked in across the board, not siloing, and we're not giving out about doctor colleagues or nursing colleagues, but AHPs can help to lift some of the burden, some of the weight here off those colleagues. So
I think just to add, there have been early discussions around development of apprenticeship programmes and pilots for certain disciplines who are more ready to go than others. For example, physiotherapy and radiography would be pretty ready to go, as would other disciplines as well in terms of content, etc. It hasn't been rolled out beyond nursing in Northern Ireland as it stands at the moment, but there is a bit of preparatory work has been done, and it could be progressed pretty quickly if we did get the green light to go ahead.
I think, sorry, Vice Chair, we would welcome any opportunity, with whether it be, an Open University or at UU, where everything is currently, where most of our courses are happening. We're open and, hopeful.
So there is funding via the apprenticeship levy. There is funding that should be associated with that sitting in the Department of the Economy, and there have been discussions ongoing, and some preparatory work has been done already on that. So we're a bit further forward, and certainly I think as a committee we're going to write looking for an update then as well, just on that. Sorry, my other questions were just about, I think you touched on it there, reform of transformation of services is huge, and absolutely everything we know that we need to be concentrating on. What do you think your priorities, what are your priorities for reform as a collective body?
I think from a physiotherapy perspective, what we need to ensure is that the continued support and rollout of first contact physiotherapy posts in primary care. I think that they're fundamental and essential to the overall transformation agenda, and actually that was something that was referenced recently in the Northern Ireland Audit Office report into primary care. And I know that it was a part of a motion that was put forward by Diane Dodds in the Assembly recently. There's a fundamental commitment in the department to the continuation and rollout of multidisciplinary teams in primary care. The difficulty is, one, funding, and two, the supply of the workforce with the requisite skills to be able to do that. And what we need to do then from a physiotherapy point of view is increase the supply that we have of those first contact physiotherapists to be able to move into those roles.
And to expand that out into the other professions, which, as I was explaining in a paper, has gone for transformation funding, and your support for that would be great. So
absolutely.
It really stems back to the advanced practice piece, and really to get practitioners into advanced practice levels. There's a lot of roles and skills that are provided by medical staff in Northern Ireland, of which we know there are a number of vacancies that could be done by AHPs. But to be able to allow time, etc., to do that, we need to backfill at the other end as well. So it's part of the whole apprenticeship undergraduate piece to allow that to happen as well. But one can't happen without the other. They're all interconnected, really.
Just with the MDT rollout, what's your assessment of how that's gone so far?
You'll probably get a good assessment from that audit office report. From a physiotherapy perspective, we reckon there's probably about 30% coverage in Northern Ireland of all GP practices at the moment. That's not where we would have wanted to be at this stage. We'd like to be further on. I think the department is looking at ways in which we can increase that. And again, I think the department is looking at maybe specific MSK modules to be put in place to increase the supply of those first contact physios to be able to move into those positions. So the department is looking into that, but it's not going to happen quickly.
And I suppose as well, beyond physio, the other ones haven't been commissioned. So we're still very much in those early stages of proposing and
the paper
lobbying.
CAFO has put forward is for a number of pilots and then assess those to see how they work. So
Okay. Thank you, Chair.
Orlia?
Yes, two very quick points. Thanks very much for all of your contributions so far. So just to go back to the meeting with the Minister that you were chatting about earlier, so I'm trying to think maybe how you move some of that on in terms of next steps. So you were talking about, and although you obviously have your own pressures in terms of workforce, you know, the fact that you're able to say that you could be providing multiple solutions to the current crisis that different parts of the health service is under at the moment. So I'm assuming you're able to provide the Minister with practical examples of how you could assist and help him with that. And it would be useful even then as a committee, you know, the more sort of specific we can be in terms of, you know, what interventions you can make as a collective to try and help ease pressures elsewhere. You know, I think that's something sort of that your professions have that maybe others that are struggling at the minute don't, you know. So the fact that you have some of that solution, you know, possibility. And then, so when the meeting with the Minister concluded, was there any follow-on in terms of next steps, follow-up meeting with the Minister or with officials, or is that in the hands of your Chief Allied Professional Officer?
At this stage, no follow-up has been planned, but obviously our door is open, and we have, as AHPF and I, worked really closely with the CAPO. I know that she has met with the Minister regularly as well. We would be delighted to follow up with the committee in terms of those practical solutions, and we have those right across the board as well, because like I said, we are realistic about the financial challenges, but we will certainly be trying to meet as regularly as we can with the Minister and keep that dialogue open, because we understand the difficult position that the Minister has too. There isn't an unlimited budget as well, but he was very open and responsive to some of the solutions that we had. But I think now the proof will be in the pudding, and we want to see some action on that.
as individual bodies, we do meet the Minister, and the Royal College met Robin Swan a number of months ago, and we have a meeting set up, or meeting requested with Minister Nesbitt as well, and then at those meetings certainly we'll be, you know, going into more detail about some of the suggestions we have as a college for podiatry, and the other colleagues are the same. So
yeah, no, so it would be useful just to get that sort of summary, but then you know, we can try and sort of capitalise on that and try and help lobby if there's good workable solutions contained within that. And then just my final point was around, see the paper that you are submitting around the transformation funding. Again, if possible, if and when that could be shared with the committee, it just sort of gives us the information, enables us to help lobby on your behalf, you know, with the department.
Yeah,
if that's possible, that would be great.
Those. Yeah,
thank you.
Absolutely.
Thank you.
Thank you. Diane? That's you now.
Right. Thank you. So just back to the issue of children with special educational needs. I was recently at a school in Limavady, special school in Limavady, and the principal and vice principal were at pains to tell us that the numbers in their school are increasing exponentially, and in fact, they may have to have a second site for the special school there. But yet, they have the same number of slots for children with speech and language difficulties as they had when the school opened. And they emphasize the real harm that is doing to children. So that if a child is nonverbal, if intervention isn't early, then the chances of that child ever becoming verbal in any sense are lessened by late interventions. So I get what you're saying, because it is an issue where children are being really harmed by not having the people there who will be able to make appropriate interventions. So I suppose my question really, and it's across the board in all of the disciplines, do you have, as part of your submissions to the department, a workforce plan that estimates the levels of recruitment that you need to do in order to provide even an adequate service, especially in special needs schools?
I'll take that to start with. Thank you so much, because you've raised a really, really vital point there. In terms of actually estimating the workforce needs, the last time that was done was for the 2018-19 review. So actually those estimations would have been carried out in 2017. They're really out of date. And it's very worrying for us. And as Cora has already said, the workforce reviews were finally published in 2022. They're already out of date and they haven't been implemented. So it's very concerning. And I suppose the quick answer is no, we don't have figures off the top of our heads. We are seeing huge increases, and the SEN pressures in the children with additional needs is just one of the areas.
Yes.
RCSLT and we released a report earlier this year called We Are the Village, which detailed an 85% increase in children waiting for speech and language therapy just between 21 and 23. So what we have seen is the workforce under more pressure post-COVID, yes, but this was increasing pre-COVID as well. Those workforce reviews of 17-18 didn't even take into account the big transformation pieces, including cancer, mental health and stroke. So when Cora was saying we need to implement them as a matter of urgency, as a bare minimum, it really is a bare minimum, because it's not even going to begin to meet the needs of the children and the adults.
Another big issue is diabetes. I didn't want to leave without mentioning that. And Diane, going back to 2018, the pediatry workforce review stated as a minimum there should be 27 undergraduate places in Ulster each year, and we've 17, and that's what's coming in, like, for the whole of Northern Ireland each year. The other professions are the same. Some of them are luckier than us; they're the bigger, more powerful professions, but there's already a gap of 17 in what was recommended, going on now somewhat. We're coming up on 10 years ago from what these were done, and that affects children with special education needs, affects people with diabetes, and the incidence of those are growing within the population. It affects the whole population.
And just Dan, to add to that as well, you're talking about the demand for children with special educational needs. Mm-hmm. In addition to the other strategies that are being developed in terms of stroke, mental health, to give you an example, when the mental health strategy was published, they subsequently published a workforce plan around the requirement and the need of various professions to deliver that. Now, just from a physiotherapy point of view, the recommendation in that workforce plan for mental health was the need for a 985% increase in the number of physiotherapists to deliver that, which is to an extent an example of how few there are working in that area. So it goes from 7 to 90 or whatever as one of the recommendations to provide and deliver that mental health strategy. But percentage wise, that's what you're looking at. And we only train 100 in Northern Ireland.
It's right across all of them. As I say, the workforce reviews that were done were just in relation to a point in time. They were not part of the bigger strategies that came thereafter. The example is the cancer strategy. So if you compare the workforce plan that was done on the back of that for all AHP disciplines alone, the difference in that and the previous AHP, workforce reviews are huge in terms of the numbers required. But I know there was comprehensive work done, particularly from a radiography perspective, as part of the cancer strategy, in recognition of what was required in terms of diagnostic and therapeutic radiographers right across the board to be able to deliver that. It was also costed as well, in addition.
I think as well, just to pick up briefly on the matter that you've raised, Diane, specifically around children, the challenges are huge, and in some areas in Northern Ireland, the longest wait for access to children's occupational therapist is in excess of 2.5 years, which is a hugely formative time in any of our lives, let alone a child. So I think that really underscores the fact that the demand is simply outstripping capacity every single day, and staff are working beyond capacity. They're working so hard, as Ruth mentioned. They're finding it really tough as well because they're not able to deliver. They're facing that moral injury. They're trying to manage expectations with patients and their families, who quite rightly are demanding better, as they should, but ultimately they just can't meet the demand. And that's specifically on occupational therapy, but right across the board, staff are working completely beyond capacity, and it's not safe and it's not sustainable either.
So can I, just to take that a step further, so there clearly is a real need for a review of the workforce across all of the allied health professionals, and that's before we get into the position of trying to rectify the issue that only 8% of GPs have full MDT teams available to them. So is the department working on that? Are you aware of what work the department is doing on that? Because I'm not, to be honest, but I will make it my business to find out. And I just think that's the need is so great. And it's at either end of that age spectrum. So if you're very young and you need that speech and language intervention, but equally if you're frail, elderly, and you need physio after a fall, or you need a little help doing something extra, I mean, those needs are very great in all of that, but we don't seem to have an estimate of the workforce that is required to actually fill the gaps. But we talk a lot about it, is the honest truth.
I think, Dan, that there is work that's ongoing, and as I referenced already, the audit report into primary care made a number of recommendations about addressing the rollout of MDTs. Funding is one area, but they also need to increase the supply of the workforce to recruit into those posts. And one of the recommendations was to look at alternative options. Now, I don't have the detail of what those alternative options might entail. To a certain extent, I have some concerns about the alternative options, which could be a dilution of the workforce that's already in existence, which to an extent isn't going to be a solution because you're spreading the resource over a wider area. But there are conversations and discussions going on, I would say, within the department and the SPPG about how they take forward the regional rollout of MDTs. But I don't have the detail of that. I think if you want the detail of that, then you need to get that from the SPPG and the department.
Can I just jump in, Diane, to your earlier question around the review? I had asked this question of the department recently myself, just in terms of, do these reviews need updated? And they said that they're not going to be updated separately anymore, but going forward there's going to be a collective allied health professions workforce review, and I think work for that is or has begun. So certainly it would help us if the committee, were to ask for that and just to encourage that along. That would be really good.
That's excellent. Thank you.
Thank you.
Okay, thank you. Look, thank you all, and as I say again, just appreciate your patience today. But we definitely really value your time and for to have the opportunity to hear the issues. A lot of our work will be ongoing outside of committee anyway, so we're happy to do whatever we can to try and support you
Really
going
appreciate
forward.
it.
Thanks so much.
Thanks a million.
Thank you.
Okay, members, we're well over time now, and I know this is going to be another busy briefing. So if I could just ask then, are there any actions coming out of that too? Yeah. So just maybe in terms of what we do coming out of that briefing, we could write to the Minister to get an update on what discussions he has had with the Department for Economy on apprenticeships in relation to healthcare, specifically maybe around AHPs, and an update on the overall AHP workforce review. I think it's very important, and I think it's something that can feed into that wider piece of supporting the health service and MDTs and all of that. So members happy enough with that one?
Yes.
Okay, members, so item number 7 is the Department of Health's domiciliary care briefing, at page 29 of your pack. You're all very welcome, and I'm really sorry for the delay today. We've a very heavy agenda and we've only 2 meetings left, so I appreciate we're trying to fit in as much as possible. But we can thank Rishi Sunak for that one. Okay, look, thank you, and we're delighted to have you here today on this very important issue, and I think even some of the information in our previous briefings tells us just how important domiciliary care is in supporting the wider issues in the health service. So I'll open up to yourselves. We have Mark McGuckin, he's the Director of Disability and Older People, Colin Dunlop, Head of Physical and Sensory Disability Unit and Elderly and Community Care Unit, and Ciara McKillop, Deputy Director of Community Care, Mental Health and Children. So you're very welcome. Some of you are back again anyway, so thank you.
Thanks, Chair. I'll make some very quick opening comments. I'll try and keep it as brief as I can. Just to clarify, it was a mistake on our part. Ciara is the Deputy Director of Older People, Children with Disabilities, Partnerships and CAMS. So we gave you the wrong steer in that, Chair, so apologies. As detailed in the briefing already provided in advance of today's meeting, you'll be aware that we deliver a significant programme of care totalling approximately 295,000 hours of care per week to in excess of 23,000 clients. However, we fully recognise there remains a substantial number of individual clients waiting a full or a part of a care package. Both the independent and statutory sectors are facing significant challenges in service delivery and capacity. There are a number of factors that have contributed to issues in delivery. These include staff recruitment and retention, and an increase in the demand for care packages that continues to outstrip available supply. The immediate focus for the department has been to stabilise the sectors and to enhance and grow capacity in the provision of home care. The briefing provided outlined that across the region, the total number of individuals either waiting a full or a part of a package has decreased by 12.5% from January 2024 to April 24. And actually, if we compare those figures slightly back a bit, from April 23 to April 24, we've seen a 17.5% decrease in unmet need. And while this is encouraging, we continue to work to ensure the capacity to deliver care packages continues to increase. We also continue to monitor the number of unmet packages, and we're working closely to improve capacity in the sector, and in particular to improve timely discharge from hospital settings when individuals no longer require hospital care. In terms of funding, expenditure by Trust on home care services across a range of programmes of cares for 22-23 was 344 million, and if you include direct payments, that goes up to just under 376 million. This is an increase of around 55 million from 21-22, when the respective figures were 289 and 316 million, including direct payments. The committee will also be aware in March the previous Minister announced a £70 million package across a range of services, and this included home care. While this funding was largely to ensure independent sector providers had the necessary funding to meet the challenges of the increase in the national living wage, the increases for home care went further than these statutory obligations. The additional funding increased the regional domiciliary care rate, which is paid largely by the trusts across the board to independent sector providers, from £18.54 to £20.1p, and this equates to around a 9% increase for this year. In addition, each trust has been allocated additional recurrent funding of just under 700,000 to establish an early review team in each area. These teams are designed to consider whether previously allocated home care packages can be reallocated to meet unmet need, and indeed if the package needs to be increased as well. It's not just about reducing the packages. This is being done by ensuring reassessment of the need of care packages within 2 to 8 weeks from discharge of hospital. There's been some very positive early indications from this work, which are showing that the right package is in place and the packages no longer required can be released for others. Between the 1st of October 23 and the 31st of March 24, just under 1,100 hours were released from people who had packages currently, which were recycled into other packages of care. The initial pilot of those early review teams has been finalised, and we intend to roll out a standardised approach across all trusts to ensure we can maximise the benefits of this early reviews on a consistent basis. Looking slightly to the future, I've highlighted we're focusing at the minute on the immediate issues and challenges that need to be addressed in regard to the provision of home care around capacity and recruitment. However, it's clear that there needs to be a more fundamental change in how we deliver the care. We recognise those working in the sector, and to help recognise those working in the sector to make the sector more resilient and sustainable in years to come. I'm sure you'll be aware of the work progressing under the Social Care Collaborative Forum. As part of this work, we're developing a plan to grow capacity in home care across the region, a new model of domiciliary care, and we're taking forward aspects of social care workforce development as part of the work streams. In addition, through the Social Care Fair Work Forum, we're looking to address a wide range of issues relating to pay, terms and conditions and career progression. We also recognise there's a need to move away from the concept of domiciliary care towards a model that actively supports the delivery of care and support in people's own homes. Work is also therefore ongoing to consider how we move away from a time and task delivery model to an outcomes-based model which will better meet the needs of individual service users. To assist with this work, we have commissioned the Innovation Lab, which is part of the Department of Finance, to assist with the design of a future delivery model for home care, focusing on cost-effective sustainability and user-centred design. The Innovation Lab has recently submitted a draft report to officials in the department for consideration. Part 1 involved a review of literature and policy landscape, and Part 2 provided a review of user research. The draft has been reviewed by Colin and folks in my team and is currently back with the Innovation Lab to produce a finalised report. We hope to be able to progress this in the coming months, albeit any new model focusing on outcomes will be more costly than the current model of delivery. I'm going to bring my opening comments in end there, Chair, to allow questions, and we're more than happy to take questions if we can answer now, or we can write back to the committee if needs be.
That's great, Mark. Thank you very much for that, and for the briefing paper as well. I just have 2 questions, because I know some of the others will have questions, and I want to give everybody a good opportunity. The first one is, and you'll be aware, at the end of April, the previous minister wrote to the Health Committee in light of the pending budget at that stage for 24-25, and outlined that the budget in front of him would have potentially meant a reduction of 1.1 million hours in domiciliary care. And as you'll imagine, and you'll know, that was very stark, and I think it was quite frightening, to be honest with you, given what we know are the huge challenges. So, I mean, is that something that is now a reality, or can you give us an understanding of what that, the budget situation at the minute in terms of any reduction to domiciliary care hours for this year?
Well, I suppose if I give you the policy position, then Ciara might be able to put more detail in terms of the operational. The Minister obviously made that comment based on the budget that he was given. That formed part of our equality impact assessment, which was published, and I think that closed, the consultation that closed earlier this week. Mm-hmm. So that is a realistic proposal in terms of to live within budget. These are the sort of issues that the department has to consider. Now, there've been other, as part of that RQIA, we detailed where trusts have been able to find cuts which would have low or medium impact. The sort of cuts to domiciliary care, and indeed the 500 potential care home beds, which was the half of the social care element of that, are what we're classing as basically catastrophic impact on the system. Now, the current minister has been clear in saying that he will not implement those sort of catastrophic cuts, but cuts will need to be found somewhere. So if we don't cut on dom care and care home beds, we will need to find that those savings elsewhere if the budget isn't increased. Now, as part of the EQI, we did note that would have a specific impact, particularly on older people and people with disabilities. So we were clear in our assessment of how that would impact if those sort of cuts were having to be made. But I think it's fair to say we're not having any plans at this stage to make those sort of cuts. I don't know, Ciara, if you have any.
No, that's it.
Okay, no, that's good to hear. And listen, I think we've all said that even at that initial stage that we were confident, I suppose, that there will be money found in year. That will hopefully alleviate that. But I think it was very alarming when people heard those figures, particularly when we know the situation. So I just wanted to be clear that that's not something that's
just to say as well, and I'm sure this was made clear at the finance briefing. Part of the savings plans we had, or the spending plans we had, always anticipated additional money in year from October monitoring, so some of that has already been built in. But if there's more money coming through, I think we're realistic as a department to say that, and as I say, the Minister's already said it, to make those sort of cuts just has wide-ranging impact across the whole system. So we need to be careful that by making cuts in one place, we don't just exacerbate the difficulties in A&E and trying to get this delayed discharges. So there is realism within the department as well, Chair, around what we can and what we can't do.
I mean, if we reduce dom care, you're just displacing the need back to the hospitals. We will just
increase
have
costs,
we will just have more people in care homes who can't leave. We'll just have more people in hospitals who can't leave, and the costs are significantly higher. So, it's not an effective. Well, it's not person centred, and it's also not an effective way of making any savings.
Yeah, no problem. Thank you. I welcome the comment you made around time and task, moving to a more outcomes based model. I think that's something I've, even just from my own background, always really advocated for. I think it's so important, and we all deal with families every day that time and task just doesn't work for. So I will be looking forward to hearing more from that. My final question, just in terms of your briefing, in terms of the numbers of people waiting on packages, whether it's full packages or partial packages, some of the trusts have relatively much lower numbers than others. Is there any work being done to look at why that is? In terms of sharing practice, or what the rationale. You don't have to give detail on what the reasons are at this stage if you don't have it, but I suppose it's just something I think it's good for us to be conscious of, and trying to figure out where.
Are you okay? I mean, underneath the Social Care Collaborative Forum, Mark and I co-chair the Maximising Capacity Workstream, and part of that is entirely around home care provision across the 5 trusts, and all the 5 trusts, plus the independent sector and service users and carers, are working with us so that we do exactly that, so that they do understand how each trust is working, how each independent sector's provider is working, so that we can share best practice. Okay. And a lot of it is around how packages are assessed in a timely way and provided in a timely way. And I mean, that's where the early review teams came from, because there was nearly an understanding that when people leave hospital, they improve whenever they get home, and if their package can be reviewed quite quickly, often people don't need the amount of care that they did at the point when they left the hospital. So we're able to recycle those hours quickly, rather than a review being left for maybe 3 months or 6 months and somebody being left with a service that they don't need exactly. So we are working with them to look at technological solutions, to look at the use of real-time monitoring and the use of apps to arrange dom care hours, so that carers and families can be involved in cancelling visits that aren't needed, so they can go to somebody else, and that this can all be carried out in real time. So I mean, I suppose we're nearly hitting limits in terms of how many more staff we can recruit and retain, so we are focusing on how we can make the best use of every hour that we have available to us. And I have to say, the independent sector and the trusts have worked really effectively and worked really well together, because we're all facing the same challenges.
And we continue to have some really challenging areas in terms of rurality and getting people to do runs in some of, particularly around the Glens of Antrim and some of the northern trust areas, and particularly some of the western trust areas as well. Mm-hmm. But equally, some of the urban areas in and around Belfast, it's equally hard to get people to take on domiciliary care, home care in those areas as well. So again, part of the work in terms of the collaborative forum is around looking at a workforce strategy going forward, how we would make home care a profession which people are more inclined to go into and stay in. We find that the transitions out of, or the attrition rates out of home care are huge. Every time Lidl's or Asda or some of the other big supermarkets advertise equally in terms of attrition from the independent sector to the statutory sector, where the terms and conditions are better. So we're working to try and make sure that there's joint joint recognition of training and other issues around a strategy for social care, which hopefully we will be publishing in the coming months.
That's really important, and I think it may be remiss not to mention, just as well as being person-centred in terms of the patient themselves, or the person who's receiving the care, is the impact on unpaid care, and how it is so, they're so dependent on getting the right support. And I've spoken to families who have a care package in place, but they're so restricted because they're running to try and do everything they need to do within a certain time frame. So any sort of flexibility around that, but really encouraged to hear around the workforce piece and in terms of retention, and we had in our last briefing, you may have heard, for the AHP's representatives, and they're talking about apprenticeships and things like that. So career pathways as well for people, I think, are very important. So thank you for that. I'm going to move on and let others in. So Linda, you're next. So thank you.
Thank you, Chair. I mean, you've touched on both of my points. I think that your specific point around that, I would call it a threat in the letter that we got from the previous minister, just to be honest, about the cut in domiciliary hours, because the reality is that would have created no savings for the health department. In fact, it would have cost you a clean fortune, because we already know that our hospitals cannot cope with the numbers of people that they're trying to deal with in their hospital beds. And the issue that all 5 chief executives raised with us whenever they came in front of us, that they said the single biggest issue that is facing them all is care packages and being able to get people out of hospital. So I just think that was complete folly, and I'm glad that the current minister's not taking that same approach. It is really very much appreciated, particularly being one of those representatives from a very rural constituency, and that's the question that I do want to ask. I mean, you've covered certainly some of what I want to ask, and I have a million questions I could ask, but I think it's important, given the challenges that we have as rural representatives, that what specific piece of work is being done around that, because that is our biggest challenge, and it is particularly around those rural areas that almost fall between trusts. So some of my areas would almost just come border on northern and southern, and the difference in service in some services, not just domiciliary care but across the board, is just unbelievable. How do we ensure, or what work is the department doing to ensure that this, for want of a better term, because I hate it, postcode lottery, but it is, stops, that everybody right across the board is getting the same type of service and has the same chance of getting a care package, because it's not fair, and it's very often that it's a pile-on of issues. So you can't get the care packages, but these are for families that are already isolated in so many other ways, because they don't have access to any other services either. And if you need to go somewhere, it's not a matter of walking down the street to your local shop, it's having to go to the nearest town. So that's not your problem, but it's a culmination of issues for people who live in rural areas. So is there any specific work going around that, around the provision of care packages for people who are in rural areas?
I mean, it's a really challenging one to answer. I mean, we are trying to maximise all of domiciliary care, and that includes those small rural villages or isolated people that need a domiciliary care package. I mean, those are the families that usually have a service from the trusts, because they have transport and they're able to meet some of those. But I mean, there's no immediate or quick answer to that one. It's just a recognised challenge. Really, there are some spots where the trusts are having to provide all of the domiciliary care because there isn't independent sector cover, and then the trusts are being challenged to find the workforce to do that, because there aren't often a local workforce available to do that. So it's just really problematic. Rurality is probably one of the biggest challenges that we face.
Then that work that's been done around innovation, is this forming part of it?
Yes,
Okay.
it is.
And we're also working, Northern Trust have come to us with a proposal, which I don't have the detail of today, but they've come to us with a proposal in terms of trying to address some of those really rural areas. And there's also a system called brokerage, which is where some of those really hard to deliver packages aren't paid for at the regional rate, because we recognise that for some of the independent folks that to do some of those really rural areas at the regional rate just isn't cost effective. So there is a system of brokerage where some of those hard to reach packages are paid at sometimes above the regional rate. That rate of £20, 1p an hour, excuse me, is the one that we pay for the vast majority of care. But there are other ones which are brokered at a higher rate, because it's just so difficult to get providers to do it at that rate. And maybe, Linda, if I could come back as well in terms of your commentary around a threat from the previous minister. You won't expect me to agree with that, but I take it where you're coming from on it. I think we just need to be very careful in terms of us saying there's no planning at the minute to cut domiciliary care. We will need to find the savings from somewhere. So the EQIA that we put out did say that was one of the things that was still on the table. So we will consider as the department the responses from the EQIA and see whatever additional money comes in from October or June monitoring, and see where that can be spread out. So I wouldn't want to be the official that said we weren't doing this, but I think that the direct question was we're currently not planning to do it. So just to clarify,
I accept that, but it would be a false economy. We all know that.
No, I totally
you know
agree
more
with
than
that
I
as
know,
well,
so
Linda.
I'm assuming that you know how much it'll cost you to not have domiciliary care packages in place. So I think anybody who knows anything, and I would like to think the minister also knows more than I know, that they know that the rest that carries. So it's going to cost a lot more to keep those people in a hospital or to deal with what happens to them at home. So I just think that's I don't want to, I suppose, dwell on, because I'm hoping you're going to be coming back to us, or at least forwarding that report on to us around the innovation stuff, or will we get inside that? So I probably want to come back more on this whenever we get that.
Okay.
Chair, thank you.
Danny?
Thank you, Chair. And even this follows on from what we were talking about earlier on today, actually. That the bottleneck within our hospitals is that bottleneck when you're trying to get out the door. And this results in overcrowding then in other departments right across, and right down to A&E and right down to the ambulances outside. So this does relate to harm that patients are being felt because of overcrowding in this. So we realise the absolute importance of domiciliary care within our communities and the effect that it has on other people. That said, I appreciate that a lot of our domiciliary care workers are vital in the communities. They're paid very, very little, in some cases minimum wage, to look after some of the most vulnerable members of our community, which I think is wrong. I absolutely think that is wrong. I want to dig into just 76% independent and 24 statutory. Is there a trend going there? Is it growing in the independent sector, or is it growing in the other?
I think it's growing slightly from 22 to 23. I think there's a 3% swing towards independent sector.
The independent sector is growing while the statutory service is decreasing. Why is that?
It's potentially because we have a bigger independent sector now who are looking to take on the work. I don't have details, Danny, in terms of how much that sector has grown. The one thing I can reassure you is that I mentioned as part of the work we're doing around the Social Care Fair Work Forum. That was established by Robin Swan when he was Minister previously. So we're looking to build an economic case which says we would like to see that sector becoming a real living wage sector as opposed to a minimum wage sector. You're right, a lot of the providers are paying minimum wage. The additional money the previous Minister put in March, we were very clear to the providers that should go directly to the workers on the ground, and we wrote out to the providers saying that. We've engaged the Economic Policy Unit from the University of Ulster to work with us in terms of making that economic case that says if we make this sector a real living wage sector, here's the benefits that would bring to Northern Ireland PLC. So we're working very hard to build that case. Now, for every pound you put on the rate, if we were to bring them into a real living wage sector, it would probably take you into around £24-25 per hour, where we're sitting at £20 an hour at the minute, roughly. So every pound you add on to that, it costs around 12 million for each pound you add on. So you're probably talking another 50-60 million to bring it up to that real living wage employer base. But when you look at to take Linda's point, when you look at how much that is costing us in terms of a health service, because we can't get people out the back door of a hospital, when we start to make those connections, it really it's a no-brainer to try and attract people into the sector, to give them a career which they will stay in. I've already mentioned about career progression, so that's another piece of work which we're progressing. I say we're working with the Economic Policy Unit. We've been talking to DFE and DOF as well around trying to make that case, and that's a case that I suppose the Minister will need to make to the Executive then, in terms of the additional funding that will take to deliver that.
I speak to carers, I absolutely get that. It's good to hear that has been discussed at least, not progressed very much at the minute, but I speak to carers all the time, and it's carers that want to do the job, but as you say, they're being attracted by, I think you mentioned Tesco's, or supermarkets have recruitment campaigns that pay more than people who are looking after very vulnerable people in our communities. That absolutely is wrong. That makes that sector very unstable then. So you're looking at vacancy rates. So the vacancy rates and the instability and the attrition rates, I think you'd referred to, Mark, are they higher in the independent sector because of that? Is that something that's...
We don't have access to the independent sector data, but we certainly would work with the trusts in SPPG. We would routinely review vacancy rates and management with the trusts, and it is something that they do work very hard to keep under control. Just to go back to talk about as part of the Social Care Collaborative Forum, the Office of Social Services and NISC are taking forward work around making social care an attractive career and developing social care, developing nearly like a home care career pathway that may lead on to nursing or social work, or may lead on to one of the AHPs, and to try to recruit a younger workforce, because I think one of the other areas of concern that we have is that the workforce profile of our home care workforce is that they're, a large proportion of them would be over 50. So I suppose we are trying to keep an eye to the future and to nearly move the age profile of the home care workforce, and to try to nearly have a career pathway through home care, that it's a stratified task, and that we are able to offer different types of care, and that can be, you can build a career entering as a home care worker. So alongside the work that they're developing, also have a social media campaign to try to encourage social care, home care, work in care homes to be really valued the way it should be. So
just I can give you details on one of the major providers, because I did ask those in coming in today, Danny. So one of the major providers who we work with in terms of home care, in 2023 they had 555 leavers, which represented 39% of their total workforce. Of those leavers, 33% exited the care sector completely. That was an increase in the same provider in 2022 had 283 leavers, so it was a 16% increase year on year of people leaving the sector. So we need to do something, because we can't continue to see those amount of people leaving. We need, as Keir said, we need to attract them, we need to make sure they'll stay, we need to pay them better, we need to make sure their terms and conditions are better. So that work is ongoing. We were very, very cognizant of that.
We know we have to reform this sector, we know we have to invest in this sector in order to help with all the other problems right along the journey throughout our hospitals, but people are leaving and people aren't coming to it, so that absolutely needs to be addressed. So thank you, much appreciated.
Okay, Diane.
Hello.
What's you now?
Hello? Yeah?
Yeah.
Can you hear me? Yeah. Okay. So just to go back to something that I find interesting at the start of the presentation. The hundreds of beds that the Minister warned would have to be cut in his pre-budget letter. What financial exercise was done by the department that led the Minister to that conclusion?
I'm sorry, Diane, I wouldn't have the exact detail on that. That was done by our finance colleagues in terms of the anticipated budget, the amount that was spent the previous year, is my understanding, and then.
But you, as a people in charge of domiciliary care, would have had an opinion to give on that, yes?
Yes.
So you agreed with the 500 bed cut that was stated in the letter.
In terms of the mathematics of what would be required to deliver the cuts that we needed to deliver in terms of the budget that was given to us.
So was this just an existential exercise rather than a practical exercise? Because you knew quite well that actually to keep these people in hospital and in acute care would be much, much more costly.
Well, I think it was a realistic exercise to say that with the budget that the department was given, these are the sort of cuts that we would have to consider. Now, I've already said that the current minister...
Sorry, no. I mean, that doesn't make any sense with respect. So in your head, you can consider these cuts, but you know from practical experience that some of these people will then continue to bed block in hospital. And you know that that's much, much more expensive. How can that be financially realistic?
Well, I don't have the detail of the financial calculations with me today that we're putting forward as part of that exercise. But I do know significant
Could the committee see those financial...
I'm not sure whether the committee... I thought the committee had a briefing on the finances a couple of weeks ago.
It had a very, very top-level briefing. But could the committee see those actual figures that led you to conclude that you would save money by cutting 500 domiciliary packages?
I'm sure if the committee wrote to the department would be able to provide more detail in terms of where those figures came from, Diane, yes.
But you didn't provide an opinion which said to the department, if you cut this, then it will cost more because these people will end up in acute hospital beds.
I suppose those conversations took place across at the highest level of the department. Opinions were formed across the department in terms of the actual realistic impact that the budget we've been given would have. Now, I've already noted that the current minister has said he's not prepared to take those catastrophic cuts because we do know it would have an impact on people's care, and we've been very clear on that. But I suppose the budget we've been given is a budget we're working within, and those are the sort of consequences of that budget that the minister had to...
I'm really not arguing with you over the budget that you've been given. No one is really in any way ecstatic about the level of funding. But what I'm actually really very concerned about is the admission today that actually to have cut that level of packages and beds would actually cost the health service more, but yet it was in the minister's letter.
Well, I think that was...
And I think that was
members said that, Diane. I don't think I said
that. Well, that seems to me to be frightening elderly folk in particular, and those with disabilities, in order to make a political point. Well, I know you can't answer that, and I'm not asking you to, but I'm making the point.
Well, it's up to you to make that political point. The department is very clear in the quality impact assessment that the department has put out around the impact that would have on people with disabilities and the elderly. So that is part of our equality impact assessment that the department published in terms of the budget we were given.
But it hasn't actually published a financial impact of cutting that amount of packages, the impact that would have, and the cost savings that would have.
No, I'm not.
Because actually, we now know from what you've said today that it wouldn't make any savings at all. In fact, it would probably cost the department more.
Well, I don't think I said that, Diane. I think it was members said that rather than me saying that. What I said was we recognise that to cut care packages in the same way when we have delayed discharge at the minute, people will be retained in a hospital bed or discharged to a care home.
And that's more expensive.
It could be more expensive, yeah. Depending on the level of care required for each individual.
It's an incredible position for the Department of Health to get itself contorted into, really.
Well, I would say that is slightly unfair because we were given a budget, we were asked to live within a budget. We made a number of proposals that would live within that budget. It wasn't just around cutting care home beds or domiciliary care packages or care home beds. The department consulted on a wide range of issues that it would need to do potentially to live within budget.
Yes.
And each of those has a knock-on consequence.
And I'm not going to continue because I've made the point, but we do know that it would be more expensive then to retain those people in hospital if there are no care home beds available for them or domiciliary packages. I mean, and that seems to me to be playing politics with very vulnerable people, to be honest. But that's fine. Can I ask a question in relation to the additional funding over the past couple of years that has been given to the sector, as the Minister said, in order to try to stabilise? And I've asked numerous questions about this in the House. I've asked the Minister on numerous times. And I do think that it is important that you assure us that the additional funding actually went into either additional jobs or additional pay to care home workers and domiciliary care workers, who, as others in the committee have said, are some of the lowest paid workers in the health and social care system. So do we have any indication when this money went to mainly independent care providers that it actually did go to those it was intended to go to?
We have no statutory remit to dictate the levels of pay that they actually provide to the workers. However, we have engaged extensively through IHCP and others, the Home Care Association, etc., in terms of engaging with the sector and engaging with those providers. We've also written out to the providers to say it was the Minister's clear intention that this would go towards the frontline workers. We also continue to monitor the levels of pay and that are going in terms of job adverts, the levels of pay that are being provided or being offered by those providers. We cannot dictate, Diane, what level of remuneration they pay. But what I would say is there's a certain levelling of the sector in its own right. If people are paying more, people will leave one employer to go to another employer. In the same way, people will leave the independent sector to go to the statutory sector. So there's a certain degree of the sector not managing itself, but it does level out. If one person is not paying to the rates we would expect them to pay, people will leave to go to another provider who is paying that. But I have to be honest that we cannot mandate or dictate what level they pay. But we have got very, very good relationships with the independent sector providers, and we believe that money is channeling into the frontline staff. Now we also understand that providers have had increased costs in terms of the cost of living increases and the cost of running their businesses as well. But part of the work we're doing, as I mentioned to Danny, around that, the Social Care Fair Work Forum will be around mandating, if we can get to a point where we would say that we would only contract with providers as a system where they're signing up to be a real living wage employer. So that is part of the work we're currently doing. But in the interim, we continue to work with all the providers to make sure that where we can, that money is going to the frontline staff.
But I understand that you've no legal remit to force that, but you've no figures either that show us that the public money that was spent, I mean, I think at one stage there was 12 million additional, am I right in that, awarded about a year, 18 months ago.
There was 23 million additional went in around 2021. Yeah. And we did see, at that stage, we did see an increase in the amount of packages that were being picked up by the independent sector. There was an increase in the amount of unmet packages being delivered. So and at that stage we did see some of the major companies advertising at increased rates. So we do keep an eye on that, Diane, but and we see that fluctuating at times. But there are some of the major providers are paying the rates we would expect them to be paying.
Okay. In terms of children and young adults with significant levels of disability, what is the position in relation to care packages and respite care? I don't know whether that is particularly your area, that can be offered to them. I know that in the Southern Trust it has been difficult to get, for example, respite care restored to the level it was pre-COVID. Now, I do understand also that there's a variety of reasons for that as well. But every single day, or every single week at least, I meet families who are desperate for additional help. And even an overnight stay every number of weeks or months would be an enormous benefit to them. And if we don't provide this, then the family carers will break down as well, and we will need to provide more. So where are we with that?
Yeah, I mean, we have struggled to get back to the levels that we had pre-COVID,
Yeah.
and there are quite a number of reasons for that. And I mean, one of the main reasons for that is, as you've described, some of the short breaks unit for children with disabilities have had to be converted to provide nearly permanent long-term care for some children who haven't been able to remain at home, and then that means that the short breaks facilities aren't able to provide short breaks, and that's certainly been a challenge in the Northern Belfast and the South Eastern trusts. We are working with those trusts to try to get that provision back up and running again, but that is challenging because of the particular needs of that group of very vulnerable young people. So, I mean, one of the initiatives that we're starting with the trusts is that the Northern Trust have a really successful Share the Care fostering scheme, where foster carers specifically look after children with disabilities. So that scheme is now up and running in both the Southern and the South Eastern trusts, and Belfast and Western are en route to getting that, because it does offer an alternative to short breaks within a specific facility. And Belfast Trust have contracted with Bernardo's to open a new facility in Randallstown, and the South Eastern Trust are hoping to open a new facility in July that will increase short break capacity. But I mean, I suppose one of the solutions is going to be being able to provide long-term placements for some of these youngsters who are currently living within the short break facilities, and that's just very detailed and very challenging work because of the particular needs of the young people. And I mean, I would say, like all of the other sectors, and you've heard this probably many, many times in this committee, we are restricted by workforce. You know, it takes a very special person to be able to look after those kids. And we are also restricted by the extremely challenging financial position that we are in at present. So I think there are a number of very challenging factors that we face, but it's something that we're working with the trusts to get back to and improve what was available for those kids before COVID and for their families.
Thank you. I mean, some of what you said is really hopeful, because I do meet parents who are in complete, like they're at breaking point at times, and it's very, very difficult. How great a priority is this for the health department?
Very big priority for me. It's one of my areas of responsibility. And I mean, I should say that I suppose that short breaks is part of a continuum of supports that we're trying to, work with the community and voluntary sector to make sure that there's early intervention and, youth clubs, and that those kids have all of the opportunities that the other kids have, and then work with the trusts to make sure that their children with disabilities social care support and their AHP support is there for those families. But I mean, we do work with the trusts a lot. They work with each other very effectively. We've spoken to the committee about the work we're doing around children with disabilities before, but probably the biggest challenges we face are the multidisciplinary workforce from social care, social work, AHPs, the workforce element, and then taking that into, I suppose, just the very tight financial envelope that we expect the trusts to have to work in.
Thank you very much. Thank you.
Thank you. I know others are looking in, but we're going to have to bring it to a conclusion there, if that's okay, because we've still got some items to get through. Thank you all again for coming today. I think, as I said, it's an ongoing piece of work, and we're keen to get as many updates particularly around the Social Care Collaborative Forum, as it moves forward as well. And we do hope that we can see some real improvement. So appreciate your work, but also appreciate you coming, taking the time to speak to us today. So thank you all.
Thank you.
Ma'am, apologies, Danny, I know you were looking back, and we need to get moving on here. The next item then is item number 8. It's a written briefing on ADHD services, and it's at page 36 of your pack. Now, I think, certainly from my own perspective, I think that we probably would be best to schedule a briefing, which maybe for after recess on this. It's a huge issue. unless anyone has anything specific they want to raise out of the briefing provided in the meantime, or, you know, are we happy with what's there and to schedule a briefing in for September time, that we can actually look into this in deeper with officials. Diane, come on ahead. Oh no, you're still muted. Go on ahead.
Okay. I think this is actually a really important issue.
Yeah.
And particularly the issue of adult ADHD services, where there is no commissioned service in Northern Ireland at all. And I know I raised this at our kind of planning day, but I do think that this is an area that the committee should urgently seek to do an inquiry into, because we have a growing number of adults who are discovering, almost through trial and error, that this may be the issue. We have other young adults who have gone and had a private diagnosis of this, but GPs will not monitor their medication that has been prescribed, so therefore they have no prescription. And the answer from the Southern Trust that I deal with is that we could refer them to mental health services. And one young woman said to me, but I'm not mentally unwell. I have a condition that needs to be managed. And I do think that this is a very, very big issue, and one that will only grow if the department do not consider commissioning services.
Yeah, no, absolutely. So I think that's why if we can do that and push forward, I know other members have raised it as well. So we can do that then and hopefully get more detail then at a scheduled briefing. Okay, members, we've done item number 9, 10 and 11. If I could refer you then to item number 12, which is correspondence. Just at page 98 and 99, from page 99 is the list of correspondence then of your pack. Just to draw members' attention to 12.4's response from the Department of Education and School Nurses. Are members content to forward the letter to the department and request a response to the committee's queries in relation to this? Yeah. We also have the latest report with the examiner's statutory rules at page 9 of your table of papers. Just ask members if they're happy to note. And are members content with the suggested actions for the remaining correspondence at 12.1?
Sure, can I, sorry, I've taken note of a piece of correspondence, but I haven't wrote down what number it was under, but it was the letter that we got in from Mesh Ireland around the care pathway for removal surgeries. And if we could maybe write off to the Minister, just ask if he is actually, if there's any consideration to maybe look at a similar pathway like over in Scotland, if we could.
I would agree with that, absolutely, wholeheartedly.
No problem. Thank you, Orlia. Are we happy then to note the rest of the briefings as set out, or the suggested actions, sorry? Yeah. Okay, item number 13, the forward work programme, which is page 133 of your pack. Just to remind members, on Monday we have the Oireachtas Health Committee visit. We're meeting at Queen's Centre for Cancer Research at 10:30 a.m, followed by lunch and a meeting here in Parliament Buildings at 1:15. Just for anyone that hasn't advised the clerk and the staff, if they are attending, can you please do so that we can make the necessary preparations. And also next Thursday, the 27th of June, we have the committee visit to the Fire and Rescue Service Learning and Development Centre at Cookstown. Again, if you could advise the committee staff if you're attending, because we are conscious that it is a bit of a distance, so want to make sure that we have at least some members there if all can't be in attendance. And the committee meeting will then be held at the usual time, 2 p.m. here in Parliament Buildings. Are members content then to note the other briefings as set out in the forward work programme?
Yep.
Have members any other business they want to raise? I just wanted to raise two things. The first thing is just to note that today the community pharmacy have a day of action, and they were staff were wearing all black, and they were putting signs in their windows as well. Just to highlight again, which we are all very aware of and we have been raising with the Minister, the serious issue of underfunding for community pharmacy. So just to highlight that as well. And the other thing, I just maybe if members are content, it's an issue that's come to me over the last few days in terms of the drive-through blood centre, which is at the St Luke's site in the Southern Trust. I've had constituents in contact with me saying that they've been advised it's been closed. Just wonder if we could write the department for an update on that, because there are quite some concerns out in the community, because it was working really, really well. It was something that was put in place during COVID, but I know certainly I've been speaking to people who are cancer patients and others who it worked really, really well for, and they are sad to see that go, because it will have a real impact. So if we can get an understanding of that and if that's definitely going ahead, and what the alternative is for anyone affected. Leah?
Just quickly, Chair, on the community pharmacy issue. So I was at a number of local pharmacies in West Belfast today, and they were saying that they have put a request in to meet with, obviously, the new health minister. If we could maybe send some correspondence to, put a wee bit of urgency on that hopefully maybe he might be able to meet with them even before the summer recess, because the issues are very critical. And again, I was hearing accounts of, medication shortages and all the rest of the stories that were heard when they presented to the committee.
No, absolutely. Thank you for that, Orly. I think that is crucial. So I'm happy enough with that. Okay, members, as I said, the next meeting is next Thursday at 2 p.m. here in room 29 in Parliament Building. So thank you all for...
Committee Room 29, Sound.